Solapur that we are hosting it. And secondly, it was challenging because this is, I think, one of the first conference that is going to be totally virtual. There is no element of actual or live program. So this was a challenge, and I think let's hope that we meet the challenge at the end of the day. That is on Sunday evening, we'll know how well we have done. And we are excellently dependent on technology, and I hope the technology that we have tried to provide is at the best. Just as a formal inauguration of the function, I wish to inaugurate this session. The conference inauguration will be tomorrow morning at around 8:45 with the traditional lighting of the lamp along with the dignitaries of the state. But today, the people who have really worked to make this conference what it is are the ones who are going to inaugurate this function today. So we are go green. The more we go green, the more healthy we are, and that's the theme of our conference. We want the doctors to be healthy, and if the doctors are healthy, then the society is healthy, and then the whole world is healthy. So with that in mind, we are going to inaugurate the conference with watering of a plant, Go Green, and I request all my team members of IMS Solapur. I'll start with Dr. Milind Shah, who is the co-chairman, Dr. Vaishali Shirsetti, Dr. Sachin More, Dr. Sudhanshu Kotadia, Dr. Kundan, Dr. Rupali. Please come forward. And Dr. Guddu Babladi, please come forward. There are actually 40 people who worked for it, but these are the 7-8 people who represent Team MASTACON, and I humbly request them to inaugurate the workshop by watering the plant. Could you please focus on the plant?
Good morning, friends. Yeah. In fact, we must give big applause to our chairman and the president of Solapur IMA, Dr. Harish Raidzur, who has taken immense efforts to make this conference very successful, and all these efforts need to be applauded with a good applause. I am requesting all my organizing committee itself to give a first big applause for Harish and entire team of IMA Solapur for this wonderful conference.
No, this is all of us. It's for all of us. And we should not applaud ourselves. We'll pat our back, and we'll allow sir to pat our back at the end of the day. Yeah, of course, sir. Could you please come?
Yeah, please.
I'm there. Yes, please come. Yeah. So that's Dr. Sachin More. That's Dr. Milind Shah, Dr. Rupali Raikhelkar, Dr. Sudhanshu Kotadia. Sudhanshu Kotadia has organized the audio visuals, and he has taken extreme pains. Dr. Kundan Sopre, Dr. Nitin Bhoge. These represent the team MASTACON. Because it's a virtual conference, we have not called everybody in. So these are the people who are here today actually working for it. So I thank you, Team MASTACON, for inaugurating the function, and over to Dr. Babladi to conduct the first session.
Good morning, everybody. It's a great pleasure to announce the MASTACON 2020 and a pre-conference workshop on COVID-19. As we know, any gathering of people, the first topic nowadays is about Corona. And this conference cannot be exception to it. And the conference is blessed with 2 Padma Shri awardees who are going to initiate the conference. And I feel that the conference has been already been blessed by these people. And I take pleasure in introducing Padma Shri Dr. Raman Ganga Khedkar. He is a head scientist at Indian Council of Medical Research. He is a recipient of Padma Shri in 2020, and he steered India exceptionally well. He steered India exceptionally well in hard times of Nipah virus and COVID-19 pandemic. He is pioneer in formulating national policies and patient empowerment in the field of HIV and AIDS. He served as Director in General at National AIDS Research Institute. And the chairman for this session are Dr. Harish Raichur sir, President IMA Solapur, and Dr. Uh, Milind Shah sir, who is a President-elect for next year. Thank you.
Good morning, sir. Before we are all eager to hear Dr. Raman Gangakhedkar. His topic is COVID-19. Are we prepared for the second wave and rational for treatment guidelines? When the first wave came in, all of us were extremely lost. Dr. Gangakhedkar and his team did give us a lot of directions as to how and what we should be doing. And now that we have certain idea, but we are really fearful and we are not certain about the second wave, and there are a lot of questions about this in our mind. And it's really a big day for us that somebody of the stature of Dr. Gangakhedkar is here to enlighten us on this topic. I request Dr. Gangakhedkar to please start his lecture. Good morning, sir, and please start.
Yes, sir.
You're on screen, sir.
Yes, yes.
Do you want to share your slides?
Let
Dr.
me
Raman?
thank, in the first place, the organizers to have had invited me to talk on this particular issue. I have slightly modified the title. We'll look at the outbreak and the treatment guidelines and where are we going from this particular place now. Now, if you look at the milestones, January 1st, the world was to wake up to a never imagined reality of becoming hostage to a tiny novel coronavirus. The first case that was seen in India was on January 30th from Kerala. And by March 11, WHO also declared this as a pandemic. If you look at the dashboard for 218 countries today, you have close to about 6 crore infected individuals by COVID-19. And of them, India ranks as second as of today. And when it comes to death, we rank as third, but perhaps it's a reflection of a large population size that we tend to see higher deaths here. But one thing to recognize that of these all 5 countries, whether it is number of cases or deaths, of more than 50% are contributed by only 5 nations, and majority of them are large, excepting for France and UK. Why are people worried? One second. Now, how do you remove? No, if I can. Anyway, one of the reasons why people are worried about the waves, there were, if you look at 1918 and 1919, and when the pandemic had actually started occurring, there were 3 waves of deaths which were essentially seen. They were documented really well in UK. This is almost more than 100 years back. But what do you essentially see? The first wave is small, the second wave is worse, it tends to be very high, and the third wave, which was found to be smaller. Basically, the interventions that were used even then at that juncture when Spanish flu was the issue was non-pharmacologic interventions, and there were no drugs the way we are handling as of now. Now, when it comes to epidemic curve that you have today of top 10 high burden countries, you suddenly start realizing the top green line is the line for USA. In USA, you had almost 3 curves, 3 waves. Now, the first wave was smaller, that was followed by second wave, and there was a third wave that came. But you must remember, when you compare the red line, which is for India, you suddenly start realizing that we had a delayed occurrence of this outbreak. And what is more important is the first wave is slowly declining at this point in time. There are certain issues which we will try to understand as we proceed ahead. Now, the question that comes to everybody's mind, the way it was asked, will there be a second wave in India? One thing which we have to realize is we don't understand certain issues. No, when do you call the curve as flattened? No, is it the degree of decline which will decide that the curve is over, or is it the time correction? No, it goes towards baseline and stays at that low level, is an issue which is still not still difficult to be understood, no, or interpreted. We are slightly different in terms of this outbreak. Our outbreak was an imported outbreak, and since it's an imported outbreak, there is heterogeneity in maturity of outbreak within different states, and that essentially tends to remain so, mainly because the seeds that came from the imported infection came to different states at different point in time. So there has to be some heterogeneity. When it comes to heterogeneity in intensity of outbreak, which is clearly reflected in the numbers, you find not all states have same intensity. That's why there are some states where you find the numbers continue to be smaller. And the reason why they tend to be smaller is you have differences in the drivers of the epidemic within states. You will find population density, which increases the exposure to a person who may or may not be infected. You have migration and immobility within large cities, which makes a huge difference in terms of exposure. And therefore, the intensity of the outbreak tends to differ not only by states, but by city, not only by cities, but also within town or urban and rural, whichever you like to consider. Mobility is something which is difficult to control in any given area. And to compound all these, you have panic and stigma, the levels of which vary by states, because you have a stigma which is highly prevalent in a society. You will find people will not come forward to go for testing, and the numbers will suddenly start shooting up after some time when the spread has occurred largely in the community. Now, if you actually look at what might happen overall, second wave in the country may not be seen in near future. The caveats for such a statement are different cities and towns in India will mature at different times, and therefore you won't see a large kind of a second wave coming at a national level. Availability of other preventive interventions like vaccine or for treatment drugs is likely to take place in near future, so it's going to impact the curve significantly. Still, the infections can increase in different population dense places. That is mainly due to the festival seasons and perhaps fatigue that is setting in the community. You might find that decrease may be seen in certain cities. What is most important thing that we need to remember? We have to avoid daily like scare, and this can only be done if we follow COVID behavior. The graph tends to tell you the classic three waves that have been described so far by different people. You find that the third one is dramatically higher, and that is perhaps a reflection of not only festivities, but the fact that people started going to their offices or places of work, and naturally both have compounded dramatically, and the third wave comes as a stronger wave. Now, what's happening in India? If you look at one of the good papers that has been published, because it has some implication in terms of management, is the death rates are declining in India. If you look at the period of testing of a person who was found to be infected and try to look at the risk of death is declining in India, but these differences were not statistically significant in this particular paper. Some of the people suddenly start thinking, is this because the virus is mutating? There is a reported mutation called as D614G. Now, this particular mutation, if you actually read the literature, these are purely association studies, and they are either association studies or standalone phylogenetic studies. We are unnecessarily drawing more inferences from the same, because these inferences cannot be robust. And what is also important that we have to remember is this virus mutates pretty slowly. there could be close to about 2 mutations per month, which is a very low rate. And since this is far lesser compared to HIV, HIV it's about 4 times higher when you compare it with SARS-CoV-2, and influenza is almost 2 times higher. The implications are good, especially that the vaccines that will come may will continue to remain effective over a period of time because the mutation rates are far smaller here. Now, why India may be having lower deaths and lower deaths? One of the things which we keep on hearing an allegation that is underreporting, but even that is not substantiated by evidences. What is more important is we could buy time during lockdown and prepare ourselves for risk mitigation. The risk mitigation approach to increase the healthcare infrastructure, ensure that people will get admissions, ensure that they will receive high nasal flow oxygen was critical, and that is actually showing you some benefits as of now. We could apply, what is most important is we could apply what the world learned in first half to improve patient management, which was not possible for the Western world, because they never went for a so strict a lockdown and a longer lockdown. The result was Italy, Spain, and US, and you name countries, no UK. They had a severe kind of outbreak, and the outcomes were also worse in terms of deaths. What is also important is there could be a factor of cross protection, whether it is from BCG, whether it is from SARS-CoV infections that have occurred in the past from viruses which are similar to SARS-CoV-2. When you think in terms of where we are going in treatment protocols, no, I liked one of the things which comes as 5 tenets to practice medicine during such a pandemic. There are first two principles that he has defined. No, there is no you need to think. What is Bayesian? Bayesian is a statistics. No, where what we do is we focus of that event or that outcome today. No, so you have to think of how did they perform before. So past history is considered as more important. Some of the could be C, D, we actually began, it began with the classic picture, like 6 blind men touching an elephant. They started thinking, oh, this might work, perhaps this drug might work, just by their own way of thinking, but none of them had a clear clue. The daunting challenge was there with respect to management with antivirals as such, because this, if you actually see this particular picture, you will realize that the inflection point with respect to change of stages in terms of clinical presentations, you will find for infection to move into respiratory mode of manifestations, you will suddenly find that this tends to occur within first 5 days. And you will realize that most often when it starts occurring, there is a lot of component that tends to come from the immune system itself. So if I have to use antivirals, then I should be able to use it as early as possible, perhaps preferably within 5 days of occurrence of this particular infection. Now that's a tough task because the person must come in time, the person must be diagnosed before that, and then the person should receive antivirals, because the manifestations that tend to come through this virus are unlikely to be lasting for a long time. What lasts is the impact of dysregulated immune system, and the complications tend to set in. Now, if you look at the drugs that we have used so far, this is a very unique situation in the history where we started trying almost everything that came to our mind, and we started dropping those which were ineffective drugs, which is classically an entirely different paradigm than what we have seen for other diseases, where we start with only supportive care and we keep on adding new and effective drugs based on the evidences that we have. Now, one of the things which we have to realize, you look at the list of drugs. You had ustekinavir, you had ivermectin, oseltamivir, then favipiravir, hydroxychloroquine, tocilizumab, convalescent plasma, interferons, vitamin C, vitamin D, and zinc, and remdesivir continues to be a controversy, which we will see subsequently. We take up remdesivir first. Now, what is most important for one to recognize is the first few studies which were done, they tended to show that it does not impact the mortality. It only impacted the time to recovery, which was shorter by 4 days. And one has to remember that this finding of only time to recovery improved with 4 days of difference between those who received remdesivir and those who received placebo, it was a secondary endpoint. By and large, in any research study, if you don't meet your primary endpoint, no, we generally don't think of secondary endpoints, mainly because your study is not adequately powered to understand the secondary endpoints, but still we manage that. We said that the regimen should be provided for 5 days and you use it in moderate to severe disease. What was also important for one to recognize that it became an emergency use authorized kind of a drug. But then Solidarity trial came, and in Solidarity trial, all the 4 drugs that were being used were suddenly found to be making no difference in terms of survival, in terms of any secondary endpoint, as they tend to say with these particular drugs. So remdesivir went out of favor. Hydroxychloroquine also went out of favor. Then lopinavir and interferons, they went out of favor. But what has happened after that? One of the things that happened was suddenly WHO said, now you should not use remdesivir. But remember that this has to be a very guarded statement or guarded understanding for us. By and large, for any effectiveness trial, we have never used the data of effectiveness of any trial to recommend or drop a particular approach unless it was backed by toxicities or safety related issues. Efficacy is an approach to choose a drug, but for dropping when you use effectiveness, it's the side effect. How severe is the side effect? But still that confusion remains. US FDA became very bold and US FDA suddenly said that we recommend use of this particular drug. If you look at WHO said that you stop using this drug. So the confusion gallows. Perhaps the truth lies somewhere in between, which we should be able to find out in few months' time, whereby we will understand where it works, if at all, if it works. Then the second trial that came, which was a good success story, was a recovery trial, where use of dexamethasone was found to reduce the mortality among patients who did not require any respiratory support at randomization. That's one thing which we must always remember. When they did not receive, when they received, oh, I'm sorry, I told the other way, when they required respiratory support. Now, if you actually look at oxygen, if they were receiving oxygen, it reduced the risk of 28 days mortality by 20%. When they required invasive mechanical ventilation, it reduced the risk by almost 35%. And therefore, it was considered as a useful drug to be used in management of COVID. Now, one of the things which we have to realize, COVID apparently is becoming a practice of doing almost nothing, as many drugs, specific drugs, are becoming ineffective. You look at ivermectin, you will suddenly find ivermectin is not a good drug, mainly because it requires, if you look at the blood levels of this particular drug in lungs, which is required to act as antiviral, you will suddenly find that you will require 100 times more human dose in order to make a difference. What is also important is there are very little studies, excepting for retrospective studies. There is no randomized control trial which has been published so far. There is no robust evidence for its current use. You look at boosted lopinavir and darunavir plus cobicistat. These are the drugs which were used in HIV. Now, these drugs in ex vivo studies or in molecular docking studies on computer, they were found to be extremely useful. But do we have actually RCT or any evidence, clinical evidence to suggest whether they could be useful? We don't have any as of now. So these have also gone out of favor. When it comes to hydroxychloroquine and azithromycin for treatment, there is no clinical benefit and the toxicity continues to be reigning supreme, and which results into longer QTC, which led to removal of these drugs from most of the guidelines. When it comes to favipiravir, this is an interesting molecule which was actually found to be, it was suggested to be useful against influenza. This is a RDRP inhibitor. This is one kind of a polymerase enzyme that the virus has, which is used in replication as such. The ex vivo studies and animal studies tended to show that perhaps this could be a useful drug. However, if you actually look at what is happening, whatever studies have been done, they tend to suggest that you need far higher dosages to make a difference. And if you use the currently recommended dosages, there is no difference in oxygen requirement or viral clearance. That's something which is critical. And Glenmark itself came out with its own study where they used two drugs, that is umifenovir and favipiravir, and they found there was no difference. But most of these are not published studies. These are mostly from news items. So essentially it says that this drug also may not be effective. Now we heard about one phenomena. We said after 5 days, there is an inflection point and perhaps respiratory manifestations become more common, which may go towards cytokine storm as a dysregulated immune system, which may cause emergence of cytokine storm. We need to provide immunomodulatory therapy then between 5 to 7 days. But the pendulum in support of use of tocilizumab is something which has been swinging over a period of time. Two studies that were done by Roche to begin with, they tended to have a conflicting results. In one of the studies, they said there is no difference. In another study, they found that it reduces the risk of putting the patient on mechanical ventilation and death by close to about 44%. But in both the studies, there was no difference in 28 days mortality. There was no difference in infection rates, secondary infection rates that can occur because you are using a monoclonal antibody, but and the other infections can be as common. But the drug went out of favor, and naturally it had to be removed from emergency use authorizations as well. One needs to remember that we tend to worry a lot about use of such monoclonal antibodies because you have a high prevalence of latent TB infection in India, and the fear is if you use it for a longer time, it is possible that they could affect the equilibrium between latency and active disease for TB. If you look at convalescent plasma, another controversial area, if you look at US FDA, they said you can go for emergency use authorization. If you look at the evidence base that we have, the Mayo study and ICMR trial, which is called as Placid trial, we found that there was no difference. Please remember, ICMR's Placid trial was the first largest global trial to be randomized control trial that was done, and it showed that there was hardly any difference, and therefore convalescent use of convalescent plasma should not be treated as standard of care. This Placid trial, people tended to criticize because we did not do the neutralizing antibody titers in donors or recipients on real-time basis. This was done once the patients had actually gone out of the study because that could not have been possible because of number of sites being high. No, we could not have done it in real time basis. Some question that this no difference finding may not be really accurate because you did not estimate the neutralizing antibody titers in donors as well as recipients. But there is a recent plasma RCT that adds to our finding of no difference. This is a smaller study, but what it essentially shows is time from intervention to death and time from intervention to improvement. Both are not different if you compare placebo with convalescent plasma. Now, one of the worries that you would have then, why does convalescent plasma not work? Mainly because it's a polyclonal antibody. It would not only have neutralizing antibodies, but other antibodies as well. The virus, by and large, dies in 10 days of being symptomatic, but the damage that you are actually trying to manage is essentially through immune response. The dose may vary of convalescent plasma, may vary by body weight. Plasma is heterogeneous, and therefore, some patients may develop autoantibodies and then develop complications, and monoclonals may have a limited impact only in very early infections. The support that tends to come is a new drug, which is a monoclonal antibody from Eli Lilly, which is called as bamlanivimab, which has received emergency use authorization in people who have mild disease and are at risk of progression. And that's something which would be crucial to be watched if we are looking at monoclonals as such at this time point. Is there any proven regimen for chemoprophylaxis? No, there is no proven regimen, perhaps because there are no biomarkers or risk scores to predict vulnerability to acquire infection. Now, my takeaways from the same are, you are more likely to add to the history if you bet on a horse or a medicine having repeated history of failure, like vitamin D, vitamin C, zinc, and whatever. Avoid fantasizing on outcomes from one patient trials, which we are likely to do, and generalize findings. Now, what matters in management is following tenet number 4, that is elevate usual care. And what is expected to be making a difference when we say the usual care? High nasal flow oxygen, prone positioning, quality management of chronic morbidity, and use of steroids. But please remember, the steroids are contraindicated among those who don't need oxygen. And if you are preferring DEXA, or if you are not going to go use DEXA, but other preparation, the dosages and the frequency of administration may vary. That's another thing that we have to remember. One of the simple takeaways that you can have: do what you know and what you are best in, and provide quality supportive care, even if it means using steroids as you do in other conditions when you don't understand the Mr. How as a syndrome. One of the worries that we had, when we started thinking in terms of recommendations nationally, was whenever you went for emergency use authorizations or even indicated that certain drugs are likely to go into research mode, they almost became standard. And that's something which is to be avoided. We should never be done. We must remember, if it is an emergency use authorization, consenting is vital, and you need to be unbiased and inform the patients of unknown efficacy and adverse events. That's something which is very crucial. Now, given these facts, some of us will wonder, will effective drugs become available? Yes, they will be. It's only a question of getting one first lead. The same thing happened in HIV with zidovudine, and you know the picture now, more than 27 antiretrovirals known. Same has happened in hepatitis C when they found that lamivudine and tenofovir among all anti-HIV drugs actually work against Hep C. Today, you are actually thinking in terms of eliminating hepatitis C. You remember that we are very smart race. We discovered a drug against smallpox, which was eradicated in 72. Now, even against that, we have discovered a drug because of fear that it could be an agent which would may be used for bioterrorism. which is called as tecovirimat, which is approved in 2018 as an antiviral. So let's hope that we will have the first lead soon. If you actually look at different drug trials that are currently going on, you find that there are a large number of groups of drug targets which are being studied as of now. The sole reason why I'm not naming names is only because we have a tendency to use this drug even if no the data is currently not available. Then the issues that come are about persisters. 87% of people are likely to have persistence of symptoms. And why is it happening? Mainly because there is unmasking of underlying comorbidities. There could be an issue related to immune response, including persistence of immune activation, perhaps post-stress traumatic disorder. Now, what is it that we are expected to do? Essentially, breathing exercises, good physical exercise, you evaluate them for cardiac issues and thromboprophylaxis for 10 days time and consult for any cardiac or neurologic issue with the consultants as such. But you must remember that we need to intensify following precautions of COVID-19 infection, even if you have had infection. The reason is very simple. The post-COVID syndrome also has a component of immunity. And if I get repeated exposure, it is possible that I might have severe post-COVID infection. One of the things which we must remember about this outbreak, 76% of the transmissions, secondary transmissions, they occur 2 days before symptoms come and 2 days after the symptoms have appeared. Now, which means they are less likely to be preventable. And we need to remember, there is age-old qualitative support, supportive care, which has proved to be preferred option. There is no known effective drug, but research may lead to development of one. Dramatic efficacy of a very quickly developed vaccine is laudable, but the administration could be challenging. The transmission dynamics of this infection tend to suggest that it may transform itself into an endemic infection. Hence, adopt the new normal of COVID-appropriate behaviors, at least for a few years in future. We need to do all that. We need to work hard because our work is the only symbol of hope for children or the future generation at this point in time. Thank you. Thank you.
Thank you very much, Dr. Raman Gangakhedkar. It was really a very lucid talk. And yes, it's always a confusion amongst all we clinicians about the second wave and all that new changes which have happened in the treatment protocols and guidelines. I'm very sure all delegates must have been benefited with your wonderful talk. Friends, as we are running short of time, we are going to start with the second lecture. You can put your questions actually in the chat box. And I am requesting Dr. Raman Gangakhedkar to answer those questions in the chat box itself for the benefit of all delegates. Yes. Yeah. So I'm requesting the digital to please offer a moment to Padma Shri Professor Dr. Raman Gangakhedkar. This is a virtual conference. So this particular momento is again a virtual momento. Thank you very much for your wonderful talk. Yeah, we are going to clap it from here. Yes. Now we'll be moved to the next talk, and I'm requesting Dr. Guddu Babladi to introduce Padma Shri Professor Dr. Shashank Joshi, who is going to speak on COVID-19 management of comorbid conditions, success and failures.
It gives me immense pleasure to present a second Padma Shri awardee of 2014, Dr. Shashank Joshi. He's an endocrinologist and he's a chair to International Diabetes Federation, IDF, of Southeast Asia. He's Dean of Indian College of Physicians. He's a member of COVID-19 State Task Force. He's a member of ICMR WHO Task Force for Management of Type 2 Diabetes. He's a past president of RSSDI and ESI. Thank you.
Yeah, thank you very much, Dr. Guddu. My co-chairperson, Dr. Sanjay Mantal, has joined actually the dais. I'm waiting for Dr. Virupaksha Joshi as well, who is going to chair this particular session. Dr. Shashank Joshi, the stage is yours.
Am I audible?
Yes, yeah, you are audible, sir.
Let me see whether I can share. You'll have to allow me to share my screen. So,
yeah, please. Yes, we are able. Yeah.
Can you see my screen?
No, not yet.
You can't see my screen.
Yes, sir.
Can you see my screen?
Yes, sir. We can see your screen, but your presentation. Oh.
It's getting opened. Give me a minute. So I think Dr. Ganga Khedkar gave you a very nice summary of, that in COVID care, everything is a learning curve. In COVID care, it is all about supportive care and comorbidity care. In COVID care, we are still elusive for that first drug to give us mortality benefit in terms of outcomes, except probably a single RCT of recovery for dexamethasone in delayed cases. So, but for that, we really have not been able to make any impact on overall COVID care. And I think he made my job very simple. And what he alluded to is, 1 minute, I think. Are my slides visible?
Yeah, your slide is visible, sir. Yeah.
So I thought, to focus on comorbidity is the key challenge in COVID care. And I think one of the key comorbidities is diabetes and hypertension and obesity. In fact, if we are able to handle comorbidities better, the outcomes can be better. And we are getting some emerging data from some parts of the world that comorbidity care helps, supportive care helps, oxygen helps, prone position helps, and probably some of the other drugs help. So obviously comorbidities have had a huge impact in the current scenario of COVID care. And I would focus predominantly on diabetes. That's going to be the challenge which I'm going to work on. So there is a clear link between diabetes and COVID. And, whether it is epidemiological, whether it is a association, we know that glucose is a perfect culture medium for all microbes, and viruses are no exceptions, and COVID was no exceptions. And the incidence is both for type 1 and type 2 diabetes, because we know that diabetes is a clear-cut, well-known entity, and we have two entities in diabetes, type 1 and type 2 diabetes. And this came from various facts, and original data came from China, that is hypertension, diabetes, and obesity, which are the three key comorbidities. In fact, the emerging data across the world shows that obesity probably is the prime driver in the pandemic today. And I think if we are able to handle people who are obese, people who have hypertension, diabetes, heart disease, probably the likelihood are that we can alter outcomes of people, because these are the people who are more likely to get severe COVID. These are the people who are likely to get critical COVID. And these are the vulnerable groups which are likely to have a higher case fatality rate and mortality. So obviously, as I said, that this was a very elegant paper published in JAMA from New York City, which had the most elegant database. And we are now in a process of compiling data from Mumbai City. And the data is almost similar, that more than 50% of people in New York had hypertension, 41% had obesity, 33% had diabetes. If you come to Mumbai City, it's probably almost 55% have hypertension and 50% have diabetes, and around 40% have obesity. So obviously, these three are the three most important comorbidities in COVID care today. And similar data has been published from elsewhere also. In hospitalized patients, if you see, the ratio is almost, 1/3 patients have hypertension, and probably, 10 to 15% have diabetes. So prevalence of diabetes in COVID is pretty large. This is the different countries, how COVID in China, COVID in Italy, COVID in USA, where the largest publication database exists is there. So this is something which we know. So 4 factors we know about association of COVID and diabetes. Number 1 is people with diabetes have increased risk of infection because they have innate immune defects, which is linked to hyperglycemia, both acute and chronic. Secondly, we all know that diabetes has exaggerated pro-inflammatory cytokine response, whether it is IL-1, IL-6, and TNF-alpha. Thirdly, we also know that in the COVID biology, something which is very, very typical is the ACE2 expression is much more. And the fourth factor, which we know in diabetics, is diabetics have a procoagulant-like state inbuilt or a hypercoagulable state. And therefore, the role of anticoagulation, the role of low molecular heparin in a diabetic COVID patient becomes more relevant, because we know that the autopsy data has very clearly shown that it is the microclots and the clots which kill in a great way. The other thing which we know, that when you look at COVID pathogenesis and diabetes, you know, the docking of the SARS-CoV-2 virus is on the angiotensin converting enzyme 2, and that triggers a serine protease called TMP-RSS2, and that really leads to this whole generation. We now clearly have data to show that there is ACE2 which is present in the lungs, the heart, the kidneys, the enterocytes, and the pancreas. In fact, after lung and heart, the third target for COVID is the gut COVID, which is the enterocyte. The fourth target for COVID is probably the kidney. And the fifth target for COVID is the pancreas. So that data is also now very clear. And clearly we have now more and more data to show by different studies on various associations, including a Mendelian randomized analysis, clearly showing that it is the expression of the ACE2, which is a putative receptor for the SARS-CoV-2. So does it really matter? Does it really, what leads the SARS-CoV-2 in a diabetic milieu to have a more severe disease? We know that if you are a diabetic and the likelihood of your neutrophil recruitment is impaired, there is impaired production of interferon production from the NK cells, the macrophage monocyte system is impaired, the antigen presentation is impaired, and the ACE2 expression is enhanced. And due to these various factors, which are the defense factors of our body, there is more likely to get a cytokine storm in a patient who is diabetic, and that's so crucial. Obviously, as I told you, that it is all about COVID and diabetes. There are 4 or 5 presentations we get. The first presentation is a pre-existing diabetic. If that patient gets COVID, then there is likelihood of a worser COVID. Second is somebody is a pre-diabetic or predisposed to get diabetes, but doesn't know who has diabetes, gets COVID, again gets a severe COVID. Third is an entity being now described as COVID-induced diabetes. We know that various viruses can induce a pancreatopathy and an isletopathy, which can cause diabetes. And now we have more and more data within India as well as outside India, which is being described of an entity called COVID-induced diabetes. An extension and subtype of this being described now from United States, even some parts of India, is a flat blush diabetes, where you get frank diabetic ketoacidosis as the first presentation. In fact, my interest with COVID started when in late March, I had a presentation of an 89-year-old man who came with frank diabetic ketoacidosis, never had diabetes in his life, and had SARS-CoV-2. And later on, we found out that he had also acute pancreatitis. The person survived with insulin drip. That time there was absolutely no care in terms of medications. The only thing people knew were empirical use of oseltamivir or lopinavir, ritonavir. Nothing else was being done. Everything in COVID was empirical, and that empiric science to evidence base, that journey, Dr. Raman Ganga Khedkar has very nicely alluded, is still elusive. And despite of that, good supportive care in an 89-year-old person with frank DKA fully survived COVID and has done extremely well. Just by simple insulin drip, a little bit of oxygen, a little bit of good critical care, you can actually make a difference. So it's something which is very reversible if we hit hard, hit early, and if we do appropriate COVID care and appropriate comorbidity care. Obviously, we have excellent data now to show that mortality goes up and glucose predicts mortality. So the big 5 in COVID care today is temperature screening, which was very, very popular and is still very popular in public spaces, is the first vital sign. Your respiratory rate is your second vital sign. Your pulse rate is your third vital sign. The blood pressure is your fourth vital sign, and glucose is your fifth vital sign. There is excellent data across the world, including Bruce Board, who's one of the pioneers from the American Diabetic Association, stating that glucose is one of the most important variables, and hyperglycemia predicts mortality even in a non-diabetic population. So an admission glucose clearly will tell you that there is a likelihood of mortality. In fact, this is the US data which shows that if there is no diabetes and hyperglycemia, the mortality is around 6.2%. And if there's diabetes and hyperglycemia, the mortality goes up to almost 30%. So that's something which has been extremely well documented now, and we know that. Why is there this link? Well, now we know it better because there's a direct link between the ACE2 pathway and the uninterrupted angiotensin damage which occurs in COVID on the various organs. So there is very clear imbalance which has been documented. This is COVID data, again published by Bruce Board, clearly showing that mortality is directly linked to hyperglycemia. So obviously the data is very clear that diabetes itself predisposes to severe COVID infection, and that's something which we know very clearly. So what are the key learning points? That with diabetes and hyperglycemia, there is predisposition to enhanced release of cytokines. There is greatly elevated levels of inflammatory cytokines causing multi-organ failure with cytokine storm. There is compromised immune system to tackle body's ability to tackle infection, impaired healing and prolonged recovery. And obviously, this is something which we all know very well. The IDF clearly recognizes that diabetes itself with COVID is a functional immunocompromised state, and glucose creates a favorable milieu for viral replication. Obviously, we don't have risk scores, but in India, what we know very clearly is that if your age is above 55, you have male gender, and there is a gender predilection because you know that there is a clear-cut androgen disadvantage or a testosterone disadvantage and an estrogen advantage. Clearly, we know hypertension, diabetes, obesity, chronic heart disease, COPD, chronic lung disease, chronic kidney disease, chronic liver disease, any immunodeficient state, congenital or acquired, or any immunosuppressant, corticosteroid, or transplant recipients are the vulnerable risk groups. And if these risk groups are reverse isolated, appropriately taken care of, you can have a case fatality rate below 0.5%. We need to be mindful that pregnancy and children below 10 need attention, but they don't follow or fall in the vulnerable category. Obviously, how do we manage these patients? Well, obviously, we need to have people which don't have COVID, but have a disease, need better management in pandemic times. And therefore, staying healthy and controlling diabetes during pandemic is extremely important. And we clearly have multiple position statements stating that people living with diabetes need to have the highest COVID appropriate behavior and need to keep in touch with their doctors and control their glucose better. Obviously, we have a lot of outpatient practical recommendations which have been globally published. And you know that diabetes care can be telecare. It can be all connected health, and we can clearly ensure that diabetics should not discontinue their therapies, ensure that they have lifestyle adherence, they do their yoga, they do their muscle building exercises, they eat less, they eat on time, they sleep at least for a good 7 hours, because these simple lifestyle measures can impact their lifestyle and glucose and can make a difference. We need to ensure that we try to keep their time in range of glucose, in an appropriate range between 70 to 180. We want to keep their A1C below 7%, and that is very, very doable. So obviously, if people living with diabetes fall ill, we know that we get a release of stress hormones, and we can have even a minor illness triggering a decay or hyperosmolar state. And that is why we need to be very, very mindful. And their hydration is the key. Seek immediate medical attention and treat aggressively and appropriately. So obviously, it's very, very important that you need to follow a very clear-cut, step-by-step approach in diabetic patients who get infections. And we need to ensure that we have simple sick day roles which are followed, where if you get a diabetic with thirst or dry mouth, passing a lot of urine, tiredness and weight loss, we need to monitor their glucose for glucose and ketones and treat them aggressively. It's as simple as that. because we all know that good glycemic control will ensure that that typical high glucose won't lead to complications. Simple aggressive treatment is all which can change outcomes. So obviously, are there treatment pathways in COVID-19 in the diabetes space? Obviously, we all know that follow simple sick day rules, use insulin, don't hesitate to use insulin. And we know that we need to follow the sick day rules for any diabetic, whether they have common cold, flu, COVID, sore throat, UTI, bronchitis, chest infections, skin infections. Just ensure that there is aggressive sick day care and never stop insulin. That's the key in diabetes care. And if you follow those simple sick day care, you have very good data which is published from all over the world that we can make an impact. A patient-centered approach should be the key. Senior citizens, severity of COVID, association of cardiovascular comorbidities, and hypoglycemia risk has to be mindful. And we need to have individualized goals for mild, moderate people with steroids. Because remember, in COVID care, you give steroids, which causes, again, a very deleterious hyperglycemia. And we have lost a lot of moderate to severe cases who were given steroids on ventilators, later on have succumbed to sepsis and hyperglycemic related issues. So remember that anti-hyperglycemic agents which cause volume depletion or hypoglycemia should be avoided. So we prefer to avoid secretagogues and SGLT2 inhibitors. We need to get dosages of anti-diabetic drugs sometimes to be reduced. We always have told that in COVID care, nutrition is the key, and outcomes have been changed in Europe and US just by simple nutrition. Eat 80% to your caloric requirement. That's a simple take-home rule in COVID care. If a COVID patient is admitted, don't give him full diet. Give him 80% of that full recommended diabetic care and dietetic care. So obviously stop SGLT2 inhibitors, stop metformin, sulfonylureas. You need to have care, and insulin is the standard of care. Obviously, we need to have a very simple approach. Home-based care can be done only by simple oral anti-diabetic agents and sometimes by insulin. But when you get the patient in the hospital, put the patient in on insulin. Obviously, try to keep better glucose control. And if the glucose goes up, don't hesitate to start insulin. We have data on each of the anti-diabetic agents and its impact on the ACE2, and I would not go into details of that. Each of these agents have very clear, areas, but the simple guidance is treat aggressively if you are a diabetic and give them good care. Have a simple approach in diabetes and ensure that your patient is taken care by simple algorithms and ensure that they get their insulin on time in sick care. And manage hypertension equally appropriately and obesity. There is a concern about the use of angiotensin receptor blockers as well as the ACE inhibitors, because people have an adverse outcome if they have underlying cardiac disease. And clearly now the data shows that we don't stop these agents, but we don't start these agents fresh if you are in COVID care. So that's something which we know very clearly. All associations have given a very clear guidelines. What is uniquely interesting is that the DPP4 enzyme, which is a serine protease, was used as a docking agent in the MERS pandemic. And we know MERS is a precursor of SARS-CoV-2, and we know it is critically important in the whole genome. And therefore, there is some suggestion that these DPP4 inhibitors may be protective in diabetes care. And that is some good data which has been published. And the data has shown that if the patient with diabetes is on a gliptin, which is now generic, which is available at low cost, it will not benefit, but it won't harm either. And there are some retrospective data. Again, we need to have good prospective data to show from Italy and from United States to show that probably if there is a DPP4 inhibitor, the mortality could be decreased. And the mortality rate, and this is the first mortality trial which was published in diabetes care, which showed that the hazard ratio by just giving a gliptin, you can see here, the hazard ratio came down to 0.44, and there was a significant impact. So obviously there is some mechanism. If you use a gliptin, probably you might have a solution of down-regulating some of the SARS-CoV-2 receptors. There is very good mechanistic science, and obviously we need to do that. So summarizing, we did come out with some guidance on diabetes and obesity as early as May. that diabetes and obesity are risk factors which confer vulnerability. Diabetes also with severe disease, it has immune defects. There is a pancreatic damage as well as stress hyperglycemia. If you have male gender, elderly, hypertension, heart disease with diabetes, it needs strict supervision. Diabetic management in hospitalization needs early supportive care, intensive glucose monitoring, insulin, and never stop insulin. Cardiovascular health is equally important. And you know that we don't stop aggressive cardiac care during COVID times. You see, the topic given to me was comorbidity care. And remember that in comorbidity care, we need to ensure that we do not stop diabetes care, because the bigger problem is as COVID pandemic ensues, we'll get a bigger tsunami of non-communicable diseases. And these are the different waves which Dr. Ganga Khedkar was alluding to. But the impact of COVID on disaster and diabetes is huge. And therefore, we encourage remote consultation and communication. We definitely need to segregate which patients need face-to-face, which patients need virtual, and which patients need to be deferred. And we need to protect our chronic care patients in a very aggressive way. We definitely need to ensure that diabetic patients need mass testing. We need to do telemedicine among COVID care. And we all know about telemedicine. I'm sure you'll have a separate topic on that. But we have various apps, and very clearly we need to ensure that we practice telemedicine in the highest ethical standards. And we need definitely to do that in a better way. Nutrition is the key in diabetes care and in COVID care. So drink adequate water, hydrate yourself. And this is something which we know that in comorbidities, if you have exception of heart failure, adequate water drinking is important. Have enough fruits and vegetables, and ensure that we have a balanced diet which is restricting on carbohydrates, and we avoid all these canned goods and canned foods. So we need to have increased focus in diabetics on nutrition, mental health, stress, and also consider non-COVID but adult vaccines. Often a flu shot to a diabetic is now a standard of care. A pneumococcal vaccine is a standard of care, which is far more impactful rather than being going on anecdotal evidence. Obviously, we know that COVID has disrupted vaccine delivery, and whatever is recommended in adult and pediatric care should be there. And therefore, we need to recognize that these are all the vaccinations recommended for diabetic, and ensure that your diabetics, when appropriately indicated, get those vaccines. And we know that we need to continue those vaccines. So obviously, diabetes is a clear risk factor. Tight glycemic control is important. We need to use telemedicine more effectively, and we need to preserve our vulnerable groups. COVID care today is, as the only thing which we know about COVID after 4 seasons of COVID and after 1 year of COVID, is we are still understanding the natural history of the disease. We are still understanding that it's a predictably unpredictable virus. We are still not having a risk prediction model which will tell us that this particular case will be silent and asymptomatic, and this particular case will become moderate, severe, critical. But the only factor which drives moderate, severe, or critical COVID are comorbidities. So if we recognize weight, waist circumference, waist circumference, diabetes, hypertension, heart disease, or any chronic illness or any major illness that will drive the pandemic. And these are the vulnerable populations. So if you are able to identify the vulnerable populations, segregate them, appropriately treat them, I think we can do a lot to save their lives. Because I think most COVID with a robust immune system, whether you give drugs or you don't give drugs, will survive on their own. And that is what the sero surveys have shown, that the exposure rate is so large that most people had asymptomatic disease, which they never knew also, and they fully recovered. But it's only the vulnerable comorbid population, which included hypertensive and diabetics, which have fallen prey to moderate or severe COVID and probably have succumbed to it. And I think we have an opportunity to intercept here in this vulnerable cohort and probably change the numbers. Because if COVID becomes a manageable disease where we are able to save every life which matters and come to a zero mortality rate, I think things will change in a big way. I deliberately avoided discussion on in general COVID, but if we have some time, I'll be happy to take any questions. Thank you so much for the opportunity. I must thank IMA Solapur and IMA Maharashtra for giving me this opportunity for being with you all on this Friday afternoon. Thank you so much.
Thank you, sir. On the behalf of 68th MASTACON from Solapur IMA, we are very thankful to Dr. Shoshank Joshi, sir, for his lucid, beautiful lecture. Precisely, this is what he said, Indian COVID-19 risk factor will definitely help all the audience. 6-day rules. The key to the success is well hydration, balanced diet, and above all, the main control of morbidities, identify and segregate the vulnerable with comorbid patients, which is the key to success of controlling the morbidity of the nation. Sir, once again we thank sir for your beautiful talk. Thank you, sir. So
yeah, friends, we are going to take a few questions for Dr. Raman Gangakhedkar and Dr. Shashank Joshi after these two talks, as we have a time with us another 5 minutes. So to start with, can I ask Sanjay to ask the first question to Dr. Shashank Joshi?
Hello, sir.
I request Dr. Raman Gangakhedkar to please unmute yourself so that we can take those questions which are there in the chat box for him as well.
Sir, monoclonal antibodies, is it available in India? Joshi, sir?
No, it is not available in India. These are trials which are recommended. So I think it's an experimental therapy, as Raman said. Raman has joined us, but I think currently it is not available in India.
Yeah.
Okay. Thank you, sir.
There is always, Dr. Shashank, people are worried about diabetes. And they say there is an increased likelihood of diabetes in post-COVID, actually, the life. So what is your say on that?
Yes, because as I said, during COVID times, there are three things which happen. One is COVID is like a post-traumatic stress disorder and like a disaster. After every disaster, we have seen, whether it was a tsunami, whether it was an earthquake, that there is an increase of diabetes, hypertension, and uncommunicable diseases. So COVID is no different from that. So we are definitely recognizing and detecting much more diabetes than what we have done before. Secondly, in COVID care, we are using some amount of steroid now, particularly in the hospitalized cases, particularly those on oxygen. Therefore, what happens is steroids unmask latent diabetes which is already present. So we are seeing this more and more. And in post-COVID care, apart from mental health, apart from neurological, cardiovascular, diabetes is equally important, or if not more.
Joshi, sir, which steroid is preferred, whether methylprednisolone or Dexa?
Data is very clear-cut with dexamethasone on mortality. The Michigan School and the Henry Ford system use methylprednisolone in the United States, but their trial was not an RCT. Recovery trial was RCT. So between the two, in ICU, our ICU doctors prefer methylprednisolone as long as you use the Dexa equivalent methylprednisolone dose, I'm okay. But if you ask me from a pure evidence-based standpoint, my first choice would be to use dexamethasone. Dexamethasone is cheap. It is effective. When we give IV methylprednisolone, you know that there is a side effect if you give it very rapidly of ventricular arrhythmias and ventricular ectopics. So my preference, if you ask me on an evidence-based standpoint, strictly from RCT, it is dexamethasone.
Yeah. Thank you, sir.
There are many questions, but few are very pertaining to this particular topic. Dr. Raman Gangakhedkar, this question is for you. With so many advertisers, so many corporate friends, they are coming out with immunoboosters. So what is your say on that, the role of immunoboosters in COVID pandemic?
No, one must recognize that in absence of evidence, if there are claims, they must be treated appropriately. What is worse is if you believe in that and drop use of COVID appropriate behavior, it would be a disaster.
Yeah. And one more actually commonly asked question about this flu vaccine. They say it offers some cross protection. People said something about the BCG vaccine as well. So what is your take on that? What about the cross protection of flu vaccine and the COVID?
There was only one association study, observational study that was done in Brazil for flu vaccine.
Yes.
However, there are no prospective studies.
Yeah.
Same is true with BCG. BCG is also association study, observational kind of approach.
Correct.
So in such studies, causality is largely unproven. You cannot be very confident what will happen. But in ICMR, we started both the studies here. However, the clinical trial for the same is currently ongoing to prove it among elderly people.
Yeah.
That data is still not out.
Correct. Yeah. Good. Yeah. Thank you. Hello.
Hello, sir. Remdesivir probably reduce the viral load. Is it the reason which reduces even reduces the cytokine storm?
It's very difficult to say whether cytokine storm is for sure related with the viral load, or is it a phenomena that may perhaps occur in different individuals given the genetic profile that they have. But we know for sure that this is known as antiviral, and the data is conflicting even as of now to recommend use of remdesivir either as a blanket recommendation for use, or even not using it may not be an appropriate statement to make. Perhaps it is useful in some subgroups, if at all.
Joshi sir, this question is for both Joshi sir and Raman sir. Sir, why the death rate is low in India with compared to ESA? Is it genetic or anything else? Or is it our immunity?
No, partly I answered. I think one of the slides actually alluded to why low death rates. I would request Shashank to answer or give his viewpoint.
I think I agree with Raman. Partly, we have a lower elderly population, though we have a higher comorbidity population. But our case fatality rate has been better because of better innate immunity is probably a plausible explanation. And as far as remdesivir was concerned, which you wanted me to also comment, I think, it improves viral clearance and recovery time in one RCT. RCTs in the remdesivir space are very conflicting. Solidarity trial is still not discontinued by WHO or ICMR. The final verdict is yet to be out. So I think, the viral clearance improvement doesn't translate into mortality evidence. And recovery time, length of stay in the hospital, length of hospitalization, all these factors have to be collated. But I think if you ask me on an overall perspective, same thing happens with favipiravir. The viral clearance is improved, but we don't have outcome data on mortality. So I think these are all learning curves, and you will have to individualize it for a given appropriate thing, and we cannot give it as an arbitrary drug for everybody.
Yeah. Thank you very much, Dr. Shashank Joshi and Dr. Raman Gangakhedkar. It was really a wonderful session we had, and we are going to have the third lecture also coming up in this session. Before that, I'm having a small, before that, we need to do the pleasant job of offering the memento to Dr. Shashank Joshi. Again, a virtual gift, virtual memento from all of us. Yeah. Thank you very much.
Thank you, sir.
Now, friends, before we go for the third talk, there is a small announcement that please don't put your names, your MMC numbers, your address in the chat box or in the question and answer, because we are missing out with certain important questions because of that. Your Zoom attendance itself is sufficient for your record, which we are going to take it for your certificate creation. So I'm requesting once again, we have put that repeatedly in the question answer box and chat box, but don't put the names and MMC numbers in the question answer sessions. With this, we are going to start with the third talk. Again, a very important talk as far as the COVID is concerned, use of mask. And I'm going to request Dr. Guddu to introduce Dr. Ashwinder Bawa from Ludhiana.
Dr. Ashwin Bawa, he is a bariatric surgeon and he's an associate professor in Department of Surgery at Dayanand Medical College, Ludhiana. He's a visiting faculty and speaker at various conferences. He is creator of a video which became popular on importance of masks in COVID times, which gave a good insight into the importance of masks. Please, sir. You can share your screen. Thank you.
Now I request Dr. Ashwinder Bawa sir to speak on everything about mask.
Hello and good morning. Am I audible?
Yes. Sir.
Yes, yes.
So I'm sharing my screen. Can you
Yep.
see, please?
Yeah, we can see your screen, Dr. Ashwind.
Yeah.
You're Dr. Ashwind. Okay, good.
HVIND.
Yeah, please.
That's okay. So good morning, everyone. I bring greetings from the Anand Medical College and Hospital. So I'm here to speak on the topic, everything about masks. I hope I do justice to the topic. So I bring greetings from the Anand Medical College and Hospital, which is a 1,600 bedded hospital in North India. Right now at the center of COVID care, we have about 100 patients still in-house admitted with us. I am a general surgeon. This is me operating in January of 2020. And this is somewhere I was operating in May of 2020. My protective gear has almost changed. You can see a loose fitting 3-ply mask on my face then, and this is how we've been operating on COVID positive patients right now. Highlights of the talk would include everything about masks and respirators, their types, taking care of the masks, and their reuse. Disclosures: I am a general surgeon. I am not a microbiologist or an infectious disease specialist. I'm still trying my best to dodge COVID-19. So this is me in our DMC family WhatsApp group early in February when I said that N95 masks, acute shortage everywhere. Situation is getting pretty grim because I could not find N95 masks anywhere. I have a confession to make. I had never ever worn an N95 mask before March of 2020. In fact, in our part of Punjab, we have a lot of stubble burning where we would, come to know about people using N95 masks while it gets really, really bad pollution wise. So what is basically COVID for healthcare workers? COVID remains a healthcare hazard. It's an occupational hazard. So OSHA, which is Occupational Safety and Health Administration, says there are three ways in which you can protect yourself, either by engineering controls or you can eliminate the hazard, which is most effective, by administrative and work practice controls, where we can change the way people work through administrative and work practice controls. Third, and the least effective, is personal protective equipment. When the healthcare worker who's getting exposed to the virus needs certain things to protect himself, this is the least effective of the defenses. But we as healthcare workers can make our defense pretty strong if we take care of everything. We all know about COVID, the way it transmits. Mainly it is droplets, either which are heavy droplets or small droplets, which we are right now talking of aerosolizations and virus being in surroundings, in hospital surroundings. So we need masks to protect ourselves. According to a basic chart, and I also am responsible for healthcare risk worker stratification in my hospital, they say that N95s are required only for aerosol generating procedures. But if we, the problem with the other 3-ply masks are that they're very loose fitting, and you would be breathing from the side of a normal 3-ply mask. So I think so you require N95 in basically all healthcare working areas. If you're in direct contact with COVID patients, if you're cleaning areas affected with where COVID patients are housed, where in the labs as well, so that you are fully protected and safe. As healthcare workers, we tend to take the infection home, and there's a risk of infecting our family members as well. So we need to take all due precautions, and I think so N95 has to be the norm till there is some effective cure or way out of COVID-19. In fact, I've tried all protective gear that is there, face shields, goggles, all sorts of N95s, sterile gowns, even the hazmat suits, everything has been tried. So basically, masks can be of 4 types. You have the normal surgical masks, you have the respirators, and N95 is called a respirator mask because you breathe through the mask. Then there are the elastomeric reusable respirators, which you can use over time and again and again. Then for final, for lab related work, or if you're operating on an antigen positive high viral load patient, you have these PAPRs, pure powered air purifying respirators, which are more stringent in terms of protecting you. Simple surgical mask I've been using as a surgeon for all the time. Never knew that I would have to read so much detail about these masks. Their lifespan is about 6 hours. We should not reuse these masks at all. If you cut open a 3-ply mask, it has 3 layers. So the outer is the fluid resistant layer. Basically, as surgeons, we wear these masks so that our droplets do not fall into the patient while operating. It has some protective value in terms of having a middle layer, which has got fibers which can protect us, give us some sort of protection for against virus particles. One must be very, very, aware of this thing, that these masks fit you very loose. So once you are in an area where there are a lot of COVID positive patients or a suspected COVID patient, or you are in an OPD where you have a patient who's got a high viral load and he's a suspected patient, and you would not be knowing that he turns out positive later. So this mask would fit you loosely, and you would tend to breathe from the side of this mask, which perhaps can expose you and to COVID-19. Let me talk about respirators. Respirators are the N95s. So N95 is not a mask, but a better word for it is a respirator. Usually they were single use before COVID-19, which caused acute shortage of these masks. Basically, these N95 masks were created for miners and people working in hazardous surroundings to protect themselves. They have a mechanism of multiple layers, microfiber, which are microfiber, and they have electrostatically charged particles inside which filter the virus particles. I must stress again that mask fit is the most crucial step in wearing an N95 mask. Gaps allow unfiltered air to go in. If you have facial hair, it is a big hindrance, because again, you would breathe in through the sides of the mask, which is not good. In N95, the N stands for non-oil resistant, and R is a bit of oil resistance, P is totally oil proof. 95 signifies 95 of the percent of particles are filtered in through the mask. The size of these particles is about 0.3 microns. 100% means that about 99.7% particles are filtered in. So this is the basic anatomy of an N95 mask. The outer is the fluid resistant layer, which gives the shape to an N95 so that it fits in. The middle is the electrostatically charged fiber layer, which helps in filtration of particles. The inner layer is the soft cotton inner layer, which does not cause any irritation to the skin. There is usually a nose clip attached so that it fits you tightly. So what happens is, as I've said, that almost 0.3 micron particles up to 95% can be filtered through an N95 mask. The larger particles, you can filter it quite easily. The smaller particles, because they move like a Brownian motion, stick to the electrostatically charged layers and prevent these particles from going into, from you breathing these particles inside. There are various types of N95 masks available in the market. Usually, I would always suggest that look for a NIOSH certified N95 mask. This is National Institute of Occupational Safety and Health. They have very stringent guidelines in terms of certifying a proper N95 mask. For example, the mask on this left side is the 3M8210. So these masks really fit well. Then, of course, at the beginning of the pandemic, there was a lot of rush with these Chinese KN95 masks. These have the ear loops. The usual NIOSH masks have a headband behind your head, and they fit you very snugly. The ear loop ones, the only problem with these is that they have been made basically for the Chinese population, and KN95 signifies that it is the Chinese certification for an N95. They would perhaps fit you loosely. In fact, if you have a small face, perhaps they would fit you well. The European, system is different in terms of classifying an N95. Always read whatever is written on the outer side of an N95 before wearing one. So the Europeans, classify them into FFPs. So an FFP1 mask filters about 80% of particles. FFP2 is an equivalent to an N95 mask, would filter about 94% of particles, and FFP3 would filter about 99% particles. My recommendation is please, please, please read the outer surface of the N95 for what you are going to wear. So these are the best ones that I found in the India market. There is always the 3M1860, which is a surgical N95 mask. It is written on the outer side of that. Rest of these are basically used by people working in hazardous environments, but can be used for medical purposes as well. The best ones manufactured in India are Venus. You can again see NIOSH written on it. There's one by Magnum. There's one by Kimberly-Clark. Always look for NIOSH certification. What the Indian government has done right now is they've started a new ISI standard called IS 9473 2002. This has been distributed by the IMA as well. So this is at par with an N95 which can be used. Always look for IS 9473, not other certifications if you're looking for an Indian manufactured mask. Always to ensure proper seal, you need to have fit testing available. Please be very finicky about the fit of your N95 mask. There should not be any air leaking from the side. Always hold on to your N95 once you wear it, tighten the nose pin and try to blow air by cupping in. The air should not leak from the side of an N95 mask. And if you're wearing glasses like me, your glasses should not even get fogged at well. Learn proper donning doffing techniques if you are going into a COVID isolation area as well. There can be inadequate seal if you have poor fit, as I've been telling. Do not be very careful about reuse of these N95 masks. If you keep reusing them, your mask will get really very dirty. In fact, those strips can break off and the nose piece can get spoiled. If it is getting spoiled, please throw away that mask. Please don't keep a beard during these times. So there are strict ways of how to don or wear an N95 mask. You have to cup the respirator, hold it tight to your face, remove your glasses if you're wearing one, then pull the upper strap back, and then the lower strap should be pulled back. Then, tighten your nose pin properly. Then always look into the mirror after wearing an N95. I would always recommend to, wear a 3-ply mask over an N95 mask, because it would protect the outer surface from getting dirty if you're planning to reuse it. So these are some of my residents, the funky ways in which they wear their N95 masks. See, this guy has kept a beard and his N95 is folding in. The other guy is crisscrossed. I see most of us crisscrossing it, thinking that it will snugly fit. But there's always a gap in between that is created, and you can get exposed if you're in fact working in an actual COVID-19 isolation area. Again, I see these sort of examples where a person is wearing a 3-ply mask under an N95 mask. See, the basic principle of an N95 mask is that it has to seal your face at all times. These would not help at all. No. So always combine an N95 with the 3-ply and a face shield, which is very much a part of standard guidelines. The CDC recommends wherever there is active transmission of COVID, you need to add protective eye care. These glasses don't work. You need to have a face shield over it. I was one of the first guys to raise awareness about the problem with the valve mask. My video came up in April. See, valve masks do not allow, just allow filtered air to go out, unfiltered air to go out in your surroundings. If your patients in your OPDs are wearing a valve mask, please request them to change it or cover them with a 3-ply mask. They would perhaps be adding to or spoiling your environment. In fact, even if you are wearing an N95 mask, your surroundings and your clinic would get contaminated, and perhaps we know of fomite transmission for COVID-19 as well. So you can see that valve open so widely. So this is a recent paper that came up, adding to what I've been saying for long. You can see that on the left is a valve mask, which is throwing out your secretions out in the open and perhaps causing infection. This is our letter to editor that got published recently on the Valve 95 mask users, the actual spreaders, the innocent spreaders of COVID-19. Why do we talk of reuse, by the way? Masks were selling at a premium since April. The prices jacked up to about 400, 500 rupees for a genuine 3M mask. There were limited supplies and the cost effectiveness. So what are the masks that you can ideally reuse? The masks which have no soiling, the nose pin is intact, the straps are intact, there should be no tears or deformation. If your mask, you're having coffee with your mask, the mask may get soiled. Do not use such masks again, and please destroy them and throw them in your red bin or whatever is standard in your area. Things to consider while reusing: chemical sterilization. Throwing disinfectant, soap, or alcohol over your mask would make it dysfunctional, and you cannot reuse it. Do not microwave your masks. Do not use high dry heat. UV light is good, steam is good, low dry heat is good, and even vaporized Terard systems, hydrogen peroxide is good enough if you want to sterilize your masks. Surface viability about 72 hours remains of coronavirus, so rotating is a viable option. So this is what I got together for you guys. Perform hand hygiene before donning an N95 respirator is basic. Inspect N95 respirator for any evidence of physical damage if you're reusing one. Don N95 respirator and do a fit check. Use surgical mask or a face shield over N95 always. Perform hand hygiene after doffing a mask. Doff mask in a clean paper bag. Those brown lifafas that we have, you can put your name and the date of your masks on top of it and use, in fact, 4 masks for 5 days. You can have 4 masks used over for about 20 days. That would be okay. You can set these masks aside for 3 to 7 days. Before donning an N95 respirator, inspect it for damage. Wear gloves to don a used N95 respirator and perform hand hygiene after that. The maximum recommended days of N95 reuse is just 5. Do not overuse your masks and be careful of using them in a sequence. If you're just, the problems with waiting and reusing these masks is that in summers we had really hot and humid weather. The masks would get really dirty. Excessive sweating is a hindrance. Your oral secretions act as an ideal culture media. And handling and risk of infection, if you're not very careful, you can cause infection. Now let me talk about filtration. When do you reuse these masks? You have to preserve the N95 filtration, preserve the N95 fit. You should not spoil the fit. Reducing bioburden. If you are any procedure that you do, decontamination should reduce the bioburden as well. If you're leaving it as such, 72 hours of non-use would make them make the virus particles inactive. Otherwise, you need UV or other things to supplement these practices. Do not introduce additional hazards. For example, ETO sterilization is known to cause cancerous things if you're using it for masks. So do not ETO your masks. I did this little thing, I converted a phototherapy unit into a UV sterilization chamber in which I placed about 4 to 8 tubes inside Phillips tubes, and I've been using it for my office products for decontamination, which gives a substitute, another method of decontamination of these masks. So always, as said, that please add a face shield while you are examining patients. In fact, as said, that this is the CDC guideline, which says that you should use universal eye protection for healthcare workers working in facilities where moderate to sustained COVID spread is occurring. So these are more protective gear which are used for surgeons. I have one here as well. So this is a full face mask by 3M. There's a half face mask on the side. These have disposable filters. The only advantage of these things is that you can use them over and over again, unless you have difficulty in breathing in. So for OTs where you're in a closed environment with perhaps a COVID positive patient or a patient who's a suspected COVID, you need 100% protection so that no air is entering. For a guy like me who's very, very, worried about catching COVID and taking it home, I have been using all these, and that's what precipitated my interest in these more funky masks. But I think so they offer more protection, and they can be reused over time. That's the most important thing. So these are the filters that are available in the market. This is P100. So as I told you, 100% means 99.7% filtration for virus, for all sorts of particles, not necessarily virus. So still, you need to fit check it. I have a long nose. I still am very careful so that this fits in very snugly. You have to clean its surfaces after use, with alcohol. You can wash this mask with a detergent, clean the external surfaces of these filters with 99% alcohol, isopropyl alcohol, which is available in the market. You can then put them in a sealed plastic bag. So this is a powered air purifying respirator. I've been using it for operating on COVID positive patients and doing isolation rounds. See, it gives you almost 100% protection. This has got a motor at the back which filters in clean air and with a HEPA filter, and then it creates a chamber inside which is positive air, and then it is a vent outside. Again, the same problem with these masks. You need to wear an N95 or a 3-ply mask with them so that you do not breathe in your particles. And in fact, if you are a carrier, asymptomatic carrier, you would be infecting your surrounding. So always use a 3-ply and an N95 mask with these as well. So I finished my talk here. I must end it by saying that safety isn't expensive. It is priceless. We need to try our best to keep ourselves safe and our parents safe and our families safe. For any further questions, this is my email ID. You can always contact me.
Sir, please unmute yourself. I am Solapur.
Yeah.
Requesting Dr. Sanjay to please ask the first question.
Sir, it's a nice lecture. Rather than saying that everything about mask, we should say all about masks. Leaving one thing, being an ENT surgeon, I say especially 2 points. One is, maybe you are seeing these things, we call nasal salute. There is a crease appears in allergic rhinitis on the nose. Okay, due to this continuous use, especially in females, they tie this face band very tightly. They causes a crease on the nose. This is one thing we noticed.
I have
got the second one is
big bent.
That we call nasal salute. That is normally seen in allergic rhinitis. Rather than that, nowadays we are seeing is this use of PAS. The other one is snugly fitting masks. Rather than saying snugly, many times what we use, these masks many times they're just around the ear rather than the complete headband. This causes the ear, whatever auricle is like bat ears. Okay, most probably that is seen in acute mastocytosis. Earlier, whenever someone is there, we can say this acute mastocytosis. In this case, this is normally seen, and this is injuring the ear. After 6 months, we may have to wear. There is a WhatsApp message also. We may have to use reverse masks.
Okay. So the interesting thing about this is, sir, that's why I say that in fact, using those KN95s, which are the Chinese ones, for our larger faces, we should use the ones with the headband. So yes, they will always be better. And in fact, if you have a problem with this nose, it's always good to put in a simple band-aid. And there are other products in the market, silicone tapes, which are available that can be used.
Okay, thank you, sir.
Yeah, good. I think we are running short of time, Sanjay. So we'll take the remaining questions in the chat box. Dr. Ashwin, it was really wonderful. And your videos are really very, very good for the public awareness as well as clearing all those doubts. On behalf of MASTACON 2020 and IMA Sholapur, we are thankful to you and want to offer you the virtual memento. Can I request Aditya to offer memento to Dr. Ashwin Bama? Yes.
Thank you.
And on behalf of me and Sanjay, we also thank the organizers for this wonderful opportunity. We are going to start with next session with another 3 lectures with new chairpersons. Thank you very much. Thank you. Thanks a lot.
I request Dr. Sada to felicitate Dr. Mantale and Dr. Shah.
Thank you, sir. Thank you.
Thank you, Kiran. That's so nice.
Thank you, ma'am. Thank you, sir. And we'll start the next session. And I request Dr. Chopde and Dr. Wankhede chair the session.
Yeah, welcome all the speakers and the delegates to IMA MASTACON 2020 hosted by Solapur IMA. We have a very interesting session coming in with neurological complications of COVID-19 by Dr. Nirmal Surya. Then COVID and the surgery by Dr. Professor Jignesh Gandhi, surgeon practicing at Mumbai, and turning adversity into advantages by Dr. Derek D'Souza at Tadegau. I mm, we will have an introduction of Dr. Nirmal Surya initially for the topic neurological complications of COVID-19.
It gives me an immense pleasure to introduce Dr. Nirmal Surya. He's a neurophysician at Mumbai. He's a founder chairman of Epilepsy Foundation of India, and he has headed various organizations in the field of social work and neurology. Thank you, sir.
Thank you very much. I am Ms. Solapur and the organizing committee of MASTACON 20. I'm here to talk about neurological complication of COVID-19. And if I may be allowed to share my screen, please. So as everyone has heard the morning session quite a bit, I could listen to a couple of sessions, and you all are aware about what is happening. Most of you know that what is been in India, and this was the data from yesterday. I don't need not tell you in detail about this, and I'm not going to tell much detail about the COVID-19 because I think most of the physician and you people know much more than me about the SARS-2, COVID-2, which affect the respiratory system. However, what here I want to emphasize is that as Shashank told you that ACE2 receptors in the tissue which determine the viral cellular tropism in human. And here is what ACE2 expression in the brain. And you could see that it is being seen in neurons, microglia, astrocyte, as well as oligodendrocyte. And therefore, not only that, the ACE2 receptors are also seen in certain part of the brain, like posterior cingulate gyrus, ventricles, substantia nigra, olfactory bulb, middle temporal gyrus. And these are some of the area, ventrolateral medulla, nucleus of tractus solitarius. And this is where the neuropathology of the COVID-2 into the neurological complications gets in. So although there are reports of neurological complication in patient with COVID-19, it is unclear. Is it a neurotrophic virus in the human? And viral neuroinvasion could possibly be achieved by several routes, and I will come back to you in some of the slides that how the olfactory nerve, vascular endothelial, and leukocyte migration across the blood-brain barrier plays a role. And you look at this, these are two basic mechanisms. One is shown to spread via the transcribinal, that is the olfactory bulb through that. And second is spread via the transsynaptic transfer, which is endocytosis through the fast axonal transfer mechanism of vesicle transport to more bacteria along the microtubule block to the neuronal cell bodies. And how the blood-brain spread occurs, it could again be because of either endothelial infection, which is through the endothelial cells, and this is the COVID virus, which transfers into the astrocyte, or through the Trojan horse mechanism causing the lymphocytes or leukocyte infection, which is through the blood-brain barrier to infect the central nervous system. So these are some of the ways which has been known. So now what are the clinical manifestation of COVID-19? An unknown proportion of patients remain asymptomatic, as we all are aware. The symptomatic patient develop clinical illness after an incubation period of about 5 days, which ranges 14 days. We all know that fever, cough, fatigue is common, but headache, myalgia, and anosmia and dyspnea are also very important. And 81% had mild illness, 14 have severe illness with ARDS, and 5 develop critical illness with ARDS and macrophage activation syndrome. And therefore, the progress along a continuum from mild to critical illness and clinical staging of COVID is useful to plan a therapeutic strategy. And it is on around 10 days that patient with systematic hyperinflammation secondary to storm or lymphohistiocytosis is important. But what is important thing is that neurological complication may come after 2 weeks or 4 weeks, and we still don't know what is going to happen to the various neurological complications after 6 months or 1 year. And we would really know in future. I'll come back to you later on with my experiences. The, the viral load peak in first week and then gradually decline. Antibody response start to increase by day 10. The viral load is directly proportional to age of the patient and that to age to receptor. And these are microRNA, which tiny molecules and direct target, which give rise to the profound virus effect, and how they are going to give the neurological complication in late stage. I'll come back to you in future. This is one of the paper which is published this month from our Indian colleagues in Annals of Indian Academy, which shows that how the host response in patient with viral infection occurs from 14 days to week 1 to week 3, week 4, week 5, week 6 and 7 and later on, and how the incubation period, acute viral phase, and the recovery period where the hyperinflammatory phase as well as pediatric inflammatory mild system syndrome, or even some patient may have still viral detected in the PCR through various method and the IgG and IgM, though PCR is negative. But neurological complication can start from day 1 and they can continue after 7 weeks. We don't even know after that how they are going to go. So neurological complication is something which is throughout this cycle. So that is what is important. So information about neurological manifestation in patient with COVID-19 is sparse, but they are coming from all over the world. And there are many case reports which are coming, and recently we have some series. And this is the first paper which was published from the Wuhan, China. And another systematic study came from France, where 49 out of 58 patients had confusion, encephalopathy, spinal tract sign on examination, as well as leptomeningeal enhancement on perfusion abnormality on MRI. So the most common neurological symptoms in COVID-19 are headache, anosmia, and agusia, which all of us know. But other finding could be stroke, impairment of consciousness, coma, seizure, and encephalopathy. And we need to be watchful. If you look at the neurological symptoms in COVID-19, like headache, dizziness, encephalopathy, cerebrovascular event, demyelination, seizures, CNS vasculitis, and then later stage, at any stage, maybe GBS, skeletal muscle injury, optic neuritis, visual impairment, 6th nerve, and I must add 7th nerve palsy also, anosmia, agosia, and generalized myoclonus, which could be seen. So CNS related symptoms are headache, dizziness, confusion, acute cerebrovascular disease, impaired consciousness, and these are in the severe, mild, moderately severe cases of COVID-19. And peripheral nervous system could be visual impairment, neuralgia, hypogeusia, anosmia, skeletal muscle. And these are some of the moderately or mildly severe cases who can have a neurological symptom or advanced symptom in the patient with COVID-19. So approximate timeline for the positive diagnostic test, clinical presentation, and pathogenesis in COVID-19 associated neurological disorder. This was published in Lancet 2020 recently, and which is divided into the blue, red, and the green, and which says that these are the diagnostic criteria for the viral RNA, IgM, IgG. These are the clinical presentation which they highlight, which could be cough, fever, tiredness, myalgia, headache, or encephalitis, myelitis, ADEM, GB syndrome, cerebrovascular disease, and the neuropathologist could be direct viral infection, para-infections, post-infection, and vascular. And again, this is starting from day 1 to 12 months prediction. So these are some of the gray area where we would know in future. Similarity between various neurological manifestations of COVID virus infection, and these are between MERS, SARS, and COVID-19. And you could see that MERS has ICH, while SARS has ischemic stroke, headache, seizure, encephalitis, encephalopathy, and neuropathy. They had anosmia and myopathy, and these are commonly seen in COVID-19. But you also have dizziness, cerebral venous sinus thrombosis, ADEM, acute encephalitis, myelitis, optic neuritis, leukoencephalopathy, acute necrotizing encephalomyelitis, MERS, PRES, and movement disorders, CNS vasculitis, cranial nerve abnormalities, myositis, and myasthenic crisis. So these are some of the new syndrome, neurological syndrome, which has been reported, and we would know again in future more and more about them. These are some of the case reported which has been published. 30-year-old Iranian female having no history of previous seizure presented with new onset of seizure. So you can have a patient with COVID-19, first time presenting new onset of seizure. One of my colleagues, Dr. Gushani, saw a patient with first time status epilepticus turn out to be COVID positive. So new onset of seizure could be one. Case 2 was a gene sequencing of virus from CSF of 56-year-old patient in Beijing, which has CSF examination confirmed the diagnosis of viral encephalitis. Case 3 was a patient with fatigue and fever and has acute myelitis treated with IVIGG. Case 4 from Italy with highest mortality rate showing neurological symptom as stroke, delirium, epileptic seizure, and encephalitis. So frequency of ischemic stroke and thrombosis increased dramatically. Case 5, they were from China, again elaborate about 5.8% cases, and stroke, hemorrhagic stroke, cerebral venous sinus thrombosis were found together in one of the patients. Case 6 was a post-viral syndrome from 5 COVID patients who developed GBS. So GBS is another common thing. So this was a recent article which has been published, and it came out 4 days ago, and I was very interested to find that frequency and severity of neurological symptom in 509 patients hospitalized for COVID-19 in Chicago-based health system. And 4 of 5 of them suffer from the neurological symptom. And what are they? Muscle pain, headache, confusion, dizziness, loss of smell or taste. Encephalopathy, which can be mild confusion to coma in the most severe cases, and average age of patient with encephalopathy was 65. So these are some of the things. 42% when they got first infection with COVID, 63% when the time of hospitalization, and 82% during the course of the disease. So it is very interesting that we are seeing more and more neurological problem. Males suffer more from brain element, have shorter time from disease onset to hospitalization, and also tend to have other disorders. And these are the neuropsychiatric neurodevelopment complications of neurological COVID-19 has been reported. Even these are the summary of clinical syndrome and potential pathophysiology. So you have anosmia, infection of olfactory epithelium, you have myalgia, rhabdomyalgia, infection of muscles or metabolic derangement, encephalopathy, you may have hypoxia, multi-organ failure or medication effect, you have seizure, which may be fever, metabolic derangement, viral encephalitis, stroke. You have acute respiratory distress, we don't know the cause. Post-viral syndrome could be mediated through the T cell, maybe acute disseminated encephalomyelitis, transverse myelitis, immune cell mediated, GBS, antibody mediated, and acute necrotizing hemorrhagic encephalopathy may be cytotoxin related. So this is another paper which came recently. It came in November 20 and from Nature, suggesting that we are seeing more and more neurological manifestation in past few months from the literature. Initially, which was just 4.2%, 34.7%. Now we are seeing that 57.4% patient may have neurological complications, and clinical outcome with instrumental will be in guiding the use of targeted therapeutic strategy for the future. And these are some of the reports which has been mentioned in These are the series of references which has been there. Now, pediatric age group with neurological complication has also been seen. They are much less as compared to the adult. And in one of the US study, which has shown that less than 1.7% of cases in the US has shown. And some of the most important form was delayed neurological complication in children can be anticipated if hyperinflammatory shock syndrome resurges after the episode. So these are some of the report which says that even pediatric patient, though less common, can have neurological complications. These are possible mechanisms which are underlying pathogenesis with neurological disease. I have mentioned to you before. So pulmonary and systemic illness, hyperinflammation, multi-organ failure, hypercoagulable state, which could give rise to encephalitis, encephalopathy, and stroke. Direct invasion of the nervous system, which may be vasculitis causing the stroke, or could be the encephalitis, muscular damage, anosmia and dysgeusia, or post-infectious immune-mediated complication like encephalitis, GBS, ANE, and ADEM. These are some of the MRI features which has been reported. You can have the small lesions due to the stroke, or mesial temporal lesion, or bilateral thalamic lesion which may have presence of hemorrhage. This could confuse with the dengue fever because you can have similar features seen in the dengue. And then these are the stroke. This is a PC infarct. This is an MC infarct. And you can also see the press. You can see the lesion in posterior aspect of the brain. These are the acute press syndrome which has been reported. So what are the possible outcomes? There may be initial infection, which may be insignificant symptom, patient improve. There may be disease progression, which increase in the inflammation, cytokinin production, impaired coagulation, increasing the risk of CV mortality rate. And then there is a severe infection, which causes vascular events such as ischemia or hemorrhagic stroke, or both, and even the venous sinus infection. So potential vulnerability of the who are at the risk. So the Dr. Shashank Joshi mentioned about diabetic. So neurological comorbidities, one, other health prevailing in the person. But people with Parkinson's disease, stroke, myasthenia gravis, or other disease that can impair mobility may also impair the lung function and can put them more risk. Patients with immune-mediated disorders such as MS, NMO, myasthenia gravis, who are on immunosuppressant drug, have again the increased risk and need to be taken care, and patients on steroid or chronic immunomodulation, children, older age people. So this is one case which we saw recently in October. Patient came from Raipur, febrile illness for 2 to 3 days in October 21st week. She was positive, given standard treatment. And on day 3, she developed acute onset of both lower limb weakness, paresthesia, loss of bladder bowel control with a sensory level. Her MRI was done, which shows dural bleed extending from D9 to D12, queried dural AVF, and she was advised further evaluation, and she was transferred to us on 20th October. With grade 0 power, higher mental function was normal. She had hypotonia, 0 to 1 in both lower limb. Reflexes were absent, so she was in a shock, and level was at D10. So we did a DSA, which was completely normal. And we repeated after that the MRI, and you could see that this is the hemorrhage, which is seen in both epidural as well as intraspinal. And the edema was going right up to the D6, D4. You can see right up to here, there is an intraspinal signal abnormality. The previous MRI was of poor quality, and we did again on 3T Tesla, and you could see that hemorrhage right in the lower part of the dorsal spine. And this is the pre-epidural bleed. So this patient, we gave her steroid, which was, we had limited record. Her D-dimer was high, CRP was high. She was initially treated. We started with IV methylprednisolone on 1 gram, and her power improved from 1 to 2. She was able to sit on the edge of bed wheelchair. However, her RT-PCR, which was negative, again came positive. MRI changes shown improvement from her first MRI. So they were reluctant to shift to the COVID ward, and they went home with physiotherapy and steroid. We have no follow-up. We will look for follow-up. So this was another report which came yesterday, 24 cases of GB syndrome from the Mumbai, and 19 patients recovered. They were treated with IV IgG and plasmapheresis. This was from group of Mega and other neurologists from Mumbai and Maharashtra. So these are the common disorder which we are seeing. I've seen many cases of post-COVID Bell's palsy and isolated cranial nerve palsy like 6 and optic neuritis. As yesterday, I saw a patient who has severely increased in involuntary tremor in the hand following the COVID-2 about 4 weeks later. This is a risk of Parkinson and dementia is real. And I had some of the neurological patients who did not have COVID, but during the COVID time, we need to study whether they had some subclinical infection, their dementia, and the Parkinson has worsened. These are, of course, general guidelines which needs to be followed in any patient with COVID, whether neurological syndrome or non-neurological syndrome. However, proposed flow chart for the CNS infection is, this is what we need to follow. We need to do a non-enhanced CT. If this is abnormal, we need to treat them as the like CT shows stroke, we need to treat them. If it is normal, then we have to manage for encephalopathy. If we need to do MRI, lumbar puncture, treat them. We have suspicion of venous thrombosis, again, we do a CT veno or MR veno. If we have ischemic stroke, we need to treat with them as we are treating. And if they come in 3 hours, we need to treat them with thrombolysis or mechanical thrombolysis. This was a consensus statement which Indian Stroke Association, as I am one of the member, has given for the COVID-19 expert group on behalf of ISA for the patient with stroke management. And this is the flow chart, which is also available on Ministry of Health, and one can follow that as a patient with a stroke comes to you. Some of the problem which can be seen is HCQ, which was initially used, can itself cause neurological adverse effect like irritability, psychosis, peripheral neuropathy, and neuromyopathy. Tocilizumab can give rise to neurological symptoms like headache and dizziness, and rare report of multifocal cerebral thrombotic microangiopathy. Remdesivir has yet no neurological adverse effect reported. We really need to look into it. There are some of the special consideration like MS, and National MS Society has released recommendation that patients who are on DMS should continue, and you need to weigh the risk and benefit of switching the patient to interferon glatiramer acetate or natalizumab, which may be much more safer. Similarly, the myasthenia gravis working group has given recommendation that you need to continue current treatment for those receiving immunosuppressive therapy, and they recommend extra vigilant social distancing, telemedicine visit. HCQ can exacerbate the myasthenia, so should be avoided. Similarly, epilepsy does not require increase in patient risk of contraindicator, and patient can be treated as follow-up, and there's only increased risk of seizure if patient has viral infection or the fever. So to highlight, COVID-19 primarily affects the lung and respiratory system. Some patients may present with neurological symptoms. We may know long-term neurological complication in future. Most common CNS manifestations include headache, dizziness, and encephalopathy. Most frequent reported PNS manifestations include loss of smell and taste, which may be a presenting symptom as well. Neurological complications are more commonly in severe ill COVID-19 patient. Stroke should be treated as per the normal guideline. Rehabilitation is going to be challenging in people with neurological disability, particularly those who are admitted in acute care in the ICU, because to treat them is going to be difficult. And here the tele-rehabilitation will be future as picked up in past few months as people are doing it. However, to conclude, maintain a high index of suspicion for COVID-19 patient with neurological symptoms. Innovation and technology must be undertaken so as to provide the best for patient health. Rehabilitation measures should be looked upon very effectively. Caution has to be practiced while managing patients undergoing immune modulator therapy. To be vigilant for potential complications that require our attention as well as early intervention. Hence our duty to protect and advocate for the most vulnerable people having MS, a stroke, or the Parkinson. And we are learning every day, and long-term neurological complication will be known over time, and we need to be very watchful and aware about this. Thank you very much for the patient hearing. I'm happy to answer if there are any questions.
Yeah. Thank you, sir. Thank you, Dr. Nirmal Surya, sir, for covering this neurological aspect of COVID-19 in details. Sir has covered all the complication, including pediatrics also. Being pediatrician, I know that COVID is less common in pediatrics, and sir has covered pediatric complication also. That means he has covered every, in minutely, he has covered all neurological part. Sir, there are some questions are there.
Yeah.
The first question is from Dr. Chandrakant. He is asking you that, have you come across major neurological involvement as a presentation in COVID-19?
Well, I have not been treating the COVID-19 patient directly, being a elderly person, and we requested not to attend. But my colleagues has seen the major cases were status epilepticus and encephalitis, and patient presenting straight away into the coma, and they found to have a COVID positive. So patient coming to you in coma and then tested positive, we do not know whether they came with the complication or it is just the other way. But yes, we have seen encephalopathy, major stroke, and status epilepticus.
Yeah. Sir, Dr. Rahul Bagde has asked question whether anosmia is more common than loss of taste.
Well, anosmia is more common, but when you have a severe anosmia, obviously your taste goes, because both are linked with the same thing. So any patient who have severe anosmia will obviously lose the taste. So anosmia is much more common than taste, because the mild anosmia may not give rise to the loss of taste.
Sir, here is one question from Dr. Amrish Shahade. He's saying that I have suffered from corona. The neurological symptoms were loss of memory, rational thinking, depression, and no recollection of events. Please let me know, is it related to the disease?
Well, see, there are two aspects, and what we are seeing is not only in the people who have suffered COVID, but also other patients who have other neurological syndrome. There's a high incidence of anxiety, depression, and fear. And as you know that when you have anxiety and depression, the lack of concentration is part of it. But like I had one patient yesterday whom I am treating for last 2 years for Alzheimer's. His symptoms has drastically increased in past few months. He's on same medication. So what I find is it is very difficult to correlate whether the non-COVID patient, why they are been deteriorating, and whether those people who have developed the COVID, whether their symptoms are real. But I would suggest you that follow it up, get your mini mental scale and the higher cognitive scale done, follow them up every 1 month and get evaluated for your anxiety and depression through the scale, and watchful it might just improve in next 4 to 6 weeks time.
Sir, there is one question from Dr. Prajakta Shitoye. Does the cause GBS, Guillain-Barré syndrome?
Well, GBS has been reported, and as I mentioned to you, our neurology group from Mumbai and Maharashtra has worked together, and they have recently reported this paper is under publication. It's about 20 cases from Mumbai itself, and they have seen patient presenting as GBS. I have seen one patient where I suspect patient came to me as GBS. I told them to go and do the COVID test. They disappear. But then later on, I came to know that they were positive. So you can have a presenting symptom of GBS. But we have also seen patients who have recovered from the COVID and developed the GBS. Thing is that you need to identify them early, treat them as the GBS, either through the IVIGG or through the plasma exchange, whichever is possible. And most of the patients do recover.
Thank you, sir. Thank you. Now we will like to hand over e-memento to Dr. Nirmal Surya, sir.
Thank you.
Thanks for time, sir.
I thank you very much for the honor, and I want to thank Dr. Sirish Valsankar, who wanted me to speak, and thank you all. Thank you very much.
Now we welcome Professor Dr. Jignesh Gandhi for the talk on COVID and surgery. He is a practicing surgeon at Mumbai. We will have his brief introduction. Dr. Bangladesh.
Hello. We as surgeons, we are always confused whether to operate on a COVID patient and when to operate and what are the protocols and whether to do a rapid antigen or do a RT-PCR. We are still lurking in darkness. So Dr. Jignesh Gandhi, who is a unit head at KM Hospital, one of the premier institute in Maharashtra, who better can guide us through the surgical aspects of COVID-19. He's a editor of Journal of Minimal Access Surgery. He's a fellow of robotic surgery, and he's a specialty board member at National Board of Examination, New Delhi. And I really commend the commitment with which he is doing, because because of the poor web access in his own in KM hospital because of the huge building. He's sitting in his car and he is presenting the talk. Thank you, sir.
Can we? Yeah, thank you so much. First of all, a good afternoon to everybody there. I'm sorry, KM has got these huge buildings, which are the British type buildings. So always we have issues about the network. So I have to unfortunately give my talk from sitting in the area where I'm sitting now. First of all, thank you, the IMA branch, Maharashtra state and the Solapur chapter. I wish I would have been there in person, but for some reason, because of the COVID, we are not meeting up. But thanks, Dr. Sachin and everyone who has been very kind enough to here today. So I have no conflicts of interest in my talk today, but I can promise you that I'm going to only talk about COVID in next few minutes as my talk goes in. It's a very nice saying from Madame Curie that nothing in life is to be feared, it is only to be understood. And now it is a time to understand more so that we may fear less. Such a wonderful quote, and I think it is so true in the times of COVID today, that it is time that we all understand, come on platforms like this so that we can get more and more less feared about the problems coming up. It was 21st March 2020 when this sudden announcement came in, and to my surprise, I had cases posted for surgery, and in the OR, there was absolute confusion, chaos, and curiosity that what exactly is going to happen next. And we just had a talk from Dr. Surya. So I can tell you that what was happening in my brain was my emotion center was absolutely stimulated on that day. I was into a strong imagination that what's going to happen. But at the back of my mind, my intuition was that we are probably heading towards a doomsday because things were not looking as good as we would have expected. And suddenly, this was me on 21st of March, and this is what I became on the 22nd of March. And on later on, this is what was me, a new hidden identity as a surgeon. And I had to tell people that it is me when I was moving around in the OR or scrubbed up because people could barely recognize me. So a lot of guidelines came into the picture regarding to COVID-19 and surgery. Some of the top guidelines came from the American College of Surgeons. And if you see worldwide, what happened was that they collected data from 60 countries. And if you see that about 30 million population, the cases got canceled, so that was a big number. More than 2 million patients of cancers were devoid of surgery, and about 70% overall cases were canceled or postponed. So this is one of the websites for anyone who wants to really see real time. These team actually tells you real time that how many cases are happening where, what is getting postponed. So it's a wonderful tool for all of us to see and follow up our cases. So what happened with COVID and surgery? Elective surgeries stopped completely because there was a big halt nationally that we should stop it. Human resources were all diverted for COVID work, and emergency surgery work was still continued in full-fledged. But now we had another breed called COVID patients having surgical emergency, which was a big challenge for all of us as surgeons. And there were safety protocols to be established in the OR so that we look after the safety of each one of us. And I quote this term called Universal COVID Guidelines, which I feel is going to be the standard for future for all of us, along with the WHO guidelines. And operating with new armamentarium, I'm sure you must have heard Dr. Baba with the mask and everything. So we suddenly came in with all the new gears around us. And the golden question was, when we will restart our elective work? So elective work stopped. So the major cases which got affected were the gallbladder disease cases, patients with hernia surgery, patients who were for interval appendectomies, benign breast disease patients, and patients with thyroid surgery. And what was the impact on surgery? Surgeon suddenly became a physician again. So we all know that we need to be a physician, but then the physician part came in again. The surgical training stopped completely. So at KEM, we had most of our students diverted for surgical work and the COVID work mix and match. So the training stopped and it got affected. The surgical research also stopped because of the COVID related work, and the surgical human resource got distributed and divided. So what happened to the emergency surgical work? The head injuries became the lowest. So surprisingly, we saw no head injuries, and the reason was because of the traffic. There was less traffic on the road, so we were having less number of COVID patients. But what interestingly we saw was that that the perforation, which you used to see very commonly, the DU perforations, enteric perforations, they all disappeared because it was a very common logic that everyone was at home eating fresh food and hardly eating outside food. So all those complications went down suddenly. But we were getting in a lot of obstructed hernias, perforated appendix, and gangrene gallbladders because these patients were sitting, waiting at home without taking any treatment. So COVID patients and related surgical emergency, it is very important for a lot of us to understand that thrombotic event is the one which has taken the major toll. Either it may be a limb extremity or it may be a GI problem. So we saw a lot of patients with ischemic problems of the limb and even ischemic bowel disease. We saw a lot of COVID-related pneumothoraxes because these patients were on a high flow oxygen, 6 liters, 8 liters, 10 liters. So we used to treat a lot of pneumothorax because of that. A lot of facial burns also came into the picture because of the overzealous use of steam. And a lot of my plastic colleagues could see a lot of facial burns coming in. And there was exacerbation of diabetes, obviously because of the COVID as well as some of the medications used in COVID, which can cause exacerbation of diabetes. So safety protocols in OR, what were the safety protocols to be followed? So doffing and donning now became the golden word. So each one of us had to get used to what is doffing and donning, and we had to practice that. We prepared ourselves for a COVID dedicated OR. So all of you who are surgeons there, it is difficult to practice, but then from positive pressure ventilation, where we have the HEPA filters from which the air freshly comes inside, we have to go into a negative pressure OR from where the outside air, from inside the outside air is to go out because it's difficult. Quite a times with the PPP, you will have a lot of sweating happening there. So you need to have those expensive head goers, but not all of us are privileged to have that. But negative pressure ventilation is what is a key. Or you can have a positive pressure ventilation with more than 25 cycles per minute so that you can have fresh air coming in very regularly. Please keep away all the non-essential items out of the OR. So it's time that we know foamite transmission is very, very common. So we used to have a lot of things in our OR. So it's time that we just keep dedicated things and keep it absolutely crisp and clear. Minimum staff and surgeon. So put people on rotation duty. So what happens is that if you have a human resource of about say 10 people, rotate the people. So what happens, the exposure also goes down, and plan your surgery. So I tell people that on Mondays and Wednesdays, you should have your OPDs. On Tuesdays and Thursdays, you should keep your minor cases, and maybe Wednesday, Saturday, you can keep your major cases. So what happens is that you're dividing your work and you're dividing the human resource, and your exposure to COVID subsequently goes down. And the patient of the movement in and out should be planned in a proper way. So there should be a proper entry and a proper exit so that your patients don't get affected and then don't spread the virus everywhere. This is one of our innovations which we made for the surgeons. It's a very simple Indian jugaad. You can just have to put an infant feeding tube, attach it with a steri strip there or to the electrosurgery probe. So what happens is you apply suction there. So every time with the aerosol, it will get affected and then the smoke will be evacuated out faster. This is another scenario. This was a patient who had come to us in emergency, and obviously about 5 to 50% of patients of COVID can have GI complications, and we all know that it is because of the ACE2 receptors, which are very common in the hepatobiliary system and next in the terminal ileum. So this was a perforation related to that. And there is also reports where tocilizumab can also induce perforation. So all of you who are still working into the COVID centers, be careful that if you have a patient with diverticulitis and is on tocilizumab, there are very high chance that it can induce, tocilizumab can induce a perforation. So one needs to be very, very careful about it. Another lady who had come in COVID times with the strangulated hernia. So she had a watchful waiting in the lockdown and see what has happened because of that she's now developed a gangrene of the underlying structures. And then you have to go in, remove the gangrenous omentum, the skin coverage, and the surgery becomes into an open surgery. The problems are apprehension, what's going to happen, the cost and the outcomes. So these are what the side effects which we saw into the COVID. And obviously these kind of cases should be done by an open technique and preferably not a laparoscopic to avoid aerosolization. Another victim of COVID is ischemic bowel disease. So thrombotic event live into ischemic bowel disease. So what happens in these kind of patients is they lead into small bowel syndrome. So this is a case where we had to resect almost about 1 feet from the DJ flexure, almost up to the IC junction, and the patient landed up with a short bowel which is less than 200 centimeters. The patient goes on TPN for a few months. So you can look what is happening because of that. And ultimately, the solution to this is small bowel transplant. And all of us must have just recently heard about this case, which was done in one of the city hospitals. And this is what I feel is sometimes a blessing in disguise. So maybe small bowel transplant didn't pick up in a big way in the past, but because of COVID, some of the cases, in challenging cases, you can do a living related small bowel transplant. This was a major problem which we used to see, gangrene of the gallbladder with impacted stones. Obviously, these patients undergo a laparoscopic cholecystectomy. Patients you would plan for a. The reason being is that in laparoscopic cholecystectomy, you will have a shorter duration of the patient in the hospital, and there will be more utilization of the bed for COVID in case if it is required. Another case where you can see a completely shattered gallbladder, because of the ischemia. There are some centers abroad where they have even done in these kind of patients analysis of the bile, and in some cases they have even found COVID into the biliary tract. So hepatobiliary tract is one where you can have presence of COVID. So if you are seeing some patients of calculus cholecystitis, which you are wondering why they are coming, think in mind and keep COVID as a differential diagnosis. So what is a gray zone today? So emergency surgery has become a very gray zone today for all of us because we really don't know. So the protocols which we follow today is we do a rapid antigen test because obviously we do not have time. We send a swab for RT-PCR, but obviously we cannot wait for it. So we do a combination of HRCT and a rapid antigen test. And we always follow protocol that we will do a damage control approach in the patient. Do not try to be very aggressive in our management and try avoiding a re-exploration. So let me give you an example of what I say a formula of S. So if you have a patient in sepsis, if the patient is in shock, please do not push the third S, which is a stitch, or the fourth S, which is a stapler, which all of us like, but do the fifth S, which is a stoma, because the sixth S is a saving life, which is going to help the patient. So if you follow this kind of dictum, we can go into a damage control approach, save the life of our patients, so that in the future we can avoid, a better lifestyle for him. So what is my mission unlock for the surgery? Scoring system. So what we have done now is we have developed a scoring system for the patients based on the quality of life and other parameters, because depending on the scoring system, what we make, we will decide which patients are going to come back and who will get a priority. Because after we are going to unlock more and more, we are going to get more and more elective patients coming up. So how does one decide? We cannot have a random thing that, okay, call this person today or this patient today. So there has to be a system which has to be in place. Malignancy cases, according to me, should get the topmost priority when we start the unlock full-fledged. Obviously, we are doing it now, but when we start again, patients with emergency admission. So say for some example, someone has come with an acute appendicitis, conserved during lockdown. He's the one who should come in during the unlock surgery mission as a top priority. Laparoscopic short stay procedure should be called in early because these are the patients where the volume of patients we are going to cover will be faster because we are going to call them for a short stay. They will go back home early. The human resources and even the health economics will be preserved. And try and keep open surgeries and benign disorders as a last priority, obviously, where you're going to plan things because these are the patients who will be utilizing your bed for a little longer time and you do not want to lose on the precious resources now. And the timing from that surgery. So a lot of people ask me that what should be the timing once you have a COVID positive patient and now he has a surgical problem. I have had an extensive discussion with my intensivist and they say that wait for at least 4 to 6 weeks in spite of the swab being negative on day 7 or day 15, because practically you can still have a chance of CRS or what is known as cytokine release syndrome even a little later date. So it's always better that we wait for day 28 or maybe more. So the literature says about 4 to 6 weeks after the COVID patient has turned negative, wait till that time, and then you can go ahead with your elective surgery. So abdominal pain and COVID, be very careful because we know that ACE2 receptors can cause problems in the hepatobiliary or the GI system and ischemic bowel disorders. So all of you are into general practice. Please be very careful about any pain in an abdomen patient coming in today who looks healthy. Beware that it could be COVID underlying. So what is the protocol? As you rightly mentioned in the beginning, so protocol today for elective surgery, what we do today is we do a COVID RT-PCR and an HRCT both. HRCT again is controversial, but the centers where we have been working, we have been doing HRCT because we know that sensitivity of RT-PCR cannot match all the time 100%. Plus, if you see the cyclic threshold, we have kept it at around 40 today. But if we increase the cyclic threshold of the RT-PCR to about 50 or 55, we will have half of India who's going to be COVID positive. So we need to even take care of that. Second thing is in the algorithm. So if the report is positive, wait 14 to 28 days. Ideally speaking, I said for 28 days, unless there is something like a semi-emergency to prevent a CRS. And if it is negative, you can go ahead and operate this patient. Now, if the patient is negative, sometimes there's a tricky situation where the patient has become positive on follow-up. Be very careful, educate these patients, go ahead with the COVID treatment again. But I don't know what are going to be the long-term medical legal issues, because patient can always tell you that you operated me and I got COVID because of that. So one has to be extremely careful about it. And the second arm is that the patient undergoes an uneventful. So we all expect that we go down this line, but this is one thing which is probably going to come in months from here. And I'm sure that this will be discussed at some point in time in this important meeting, what we are having. So looking forward, I personally feel that we will come out with protocols for information for the patient and relatives. So I have some few tips for each one of us who's going to be in practice. Make a small pamphlet about hospital new etiquette. So maybe you can have an information brochure that where the patient is supposed to come, where the relative is supposed to sit, what are the do's and don'ts for the relatives. That will help. Second thing is educate the patients by sending them small video clippings of how people will look around. Because when we are wearing PPE, with PPE, everyone looks the same, the doctor and the nurse. And a lot of times I've had complaints where patients have told the relatives later on कि मुझे तो सुबह से कोई देखने को आया ही नहीं, because everyone looks the same. So there are small brochures where you can put up, you're a doctor, you identify yourself and do that. Third is communication problem is a big thing. So telephonic and the video call should be now made a standard of care. And try to use this information technology, like I'm doing this talk to you because of the presence of telemedicine, that we can reach each other very comfortably. So use that. Informed consent. I feel that we do not have time to sit with the relatives and talk for hours together on explaining a consent. So make pre-recorded videos of certain procedures which are doing commonly, like gallbladder, appendix, hernia, and tell the patient that go through this, which will be in your own voice. And if you have questions beyond this, I will sit with you for a few minutes and then we can go through this. I think this will prevent the aerosolization and the contact with each other very, very comfortably. You can do it, nicely. And post-surgeries, do's and don'ts, because a lot of our Indian patients want to know everything in detail. Operation नंतर खायचं काय, करायचं काय, कसं चालायचं, कसं करायचं. So you don't want to keep on talking. So I was told by one of my colleagues very nicely, and we use a formula of 3/2. That means we used to call in the patient, 3 minutes of clinical discussion, 2 minutes of examination, and we are done. Because then you reduce your chance or exposure to the patient in terms of aerosol liberation. So post-surgery do's and don'ts, make some small pamphlets, give it to the patient well in advance and tell him की ह्याच्यामध्ये सगळी माहिती दिलेली आहे. याच्या अतिरिक्त तुम्हाला काय असेल तर you let me know. And finally, record all the conversations. This is what I have learned, because pre and post recording is very, very important from medical legal point of view. I don't know whether it is right or wrong, but only time will say that. But I personally feel that it is a time which everyone is learning. We have surprises every day. So please try to record as much as you can possible. Document everything properly so that you don't have hassles in the future. Look at this video. This is one irresponsible behavior, and this is what I keep on showing people, which can create a disaster. No? So this is a way where one small mistake by one person can lead to a disaster. And that is me. And I always say that this first wave should be the final wave. I preach and pray to everyone that we all should come together and we should not have the second wave. Thank you very much, all of you. And thanks, Dr. Sachin Jamna and everyone at IMA for giving me this opportunity. I'll be very happy to answer any questions. These are my contact points. I put up a lot of educational videos on my YouTube. You can put up my name there. That's my email for you. And that's a contact for WhatsApp. I'm happy to be available to educate or discuss any case anytime. Thank you very much for your patient hearing.
Thank you. Thank you, sir. Thanks, Dr. Jignesh Gandhi, sir, for such a wonderful lecture on COVID and surgery. And thanks for giving universal COVID guidelines and protocols followed in your esteemed institute. And what you have done is after unlock, successful unlock 1, 2, 3, you have given mission unlock surgery. That is good. Now I think that all the surgeons can become surgeon again and not physician now. Any questions? There are some questions. Question from Dr. Sushant Yoge. He is asking which test should be done pre-operatively, whether rapid antigen test or RT-PCR test.
So if you ask me, as I highlighted, RT-PCR absolutely is a gold standard, but combine RT-PCR with an HRCT test, because we have done all permutation combinations and we have found out that this combination works well. Rapid antigen gives you a pseudo feeling that, okay, fine, the patient is negative and let's go ahead. But the moment the patient is going to turn positive, A, you are worried about yourself, and B, you are worried about the medical legal issues. So I think RT-PCR is the way forward, combined with an HRCT, and do it within the first 48 hours. So RT-PCR 48 hours prior, day of admission HRCT, and then go ahead with the surgery.
Okay, thank you, sir. There is one question from Dr. Swati. She's mostly obstetrician. She's asking question, in obstetrics emergency, how to handle situations?
So, madam, as we said, obstetricians are always 24/7 on call. So what I feel is, wearing, if you saw the first part of my talk, I was wearing those HEPA filters on my face. So I think the best part is do a rapid antigen test and take what I call it as universal COVID precautions. So once you take universal COVID precautions with the right PPP, aerosolization, and staggering your human resource, that means you come into the picture to assist or do the final part. One team comes who does the painting and draping part and assisting you. Once the surgery is done, you wash out. The second team comes in and who does the closure part, and then you are done. So if you spare the timing, your aerosolization contact will go down.
Yeah. Sir, there is one question from Dr. Abdul Hamid. He is asking, what's the logic of decreased surgical and medical emergencies during COVID? You can take the surgical part.
Yeah. So he's saying why the numbers are gone down.
Yeah, he's asking what is the logic of decreased surgical and medical emergencies?
Yeah, so the decrease, as I told you very clearly, people were eating home-made food. A lot of us were also preparing a lot of recipes from the YouTube. I have also done it myself. So everyone was eating fresh food. No one was eating junk food. So enteric perforation was out. DU perforation and H. pylori was out because we were not eating outside, not exposed to contaminated food and water. So I think that's a major reason why we saw a number of. But I can tell you, it was like a spring action. It was not that the numbers were down, but the second spring sarge wo sab dabe hue the. Now they are all coming out. I think it was probably a wrong reflection, but eating healthy food made a lot of difference. Like wearing mask today, all of us, is predicted that by 2024 we may probably see a disappearance of tuberculosis, which is going to be such a big thing.
Sir, there is one question from renowned surgeon Dr. Sachin Jamma, sir. Is there any role of rapid antigen test?
So rapid antigen test is, as I told you, only limited for an emergency situation, because it might just tell you what is exactly is happening. Otherwise, I don't see any role of RAT apart from an emergency situation where you have to immediately take up the patient in a matter of few hours. That's it. Otherwise, I see the sensitivity of that test is not very good.
Yeah. Sir, there is one question from Dr. Neeraj Murke, Amravati. How to decide whether the PPE what we use is a good one?
Dr. Neeraj, a very good question. But the thing is that just stick to what your hospital is going to provide. If you are in a corporate or a medical college setup, if not, if you are in your own setup, then there are PPE. There is a chart available of PPE 1, 2, and 3. So PPE for an OPD will be different. So what you saw my photograph, that was PPE for the OPD. What you saw me with the HEPA filter, that was a PPE for the OR. So you will have PPE level 1, 2, and 3 depending on where you're going to sit.
Yes. Thank you, sir. As a surgeon cannot do virtual surgery, but we at MASTACON can give a virtual memento for this wonderful talk. Presenting this e-memento to you, sir.
That is so nice of you. Thank you very much. And I wish and pray to all of you, and even the Lord at Solapur, that please see to it that we don't get the second wave. Thank you so much.
Thank you, Dr. Jignesh Gandhi, sir. We have one more interesting topic coming up with turning adversity into advantages by Dr. Derek D'Souza at Talegaon. We will have his brief introduction.
In these testing times of COVID, both socially as well as emotionally, Dr. Derek D'Souza is going to guide us how we should go ahead with the social as well as the health issues about COVID and take it very positively and make adversity into a advantage. He is an international trainer and consultant of organizational psychological medicine. He is director of National Bioethics and Curriculum Implementation Center, Pune, India. He is he is head of training courses and national faculty member of 3T Bioethics Training India program of UNESCO Chair in Bioethics, Haifa. Over 2 decades of meritorious service in Army Dental Corps. Thank you, sir.
Thank you, sir, for that kind introduction and your kind words. It is indeed an honor and a pleasure to speak to all of you on this very auspicious occasion. And I'm glad that despite COVID and despite the distance that separates all of us, we are all united in this common mission. May I share my screen, Chairperson? I hope that is visible and I'm audible to everyone.
Yes, sir.
Okay, thank you. So once again, my compliments to the organizers for putting together this very professional conference. I've been listening in to the speaker since morning, and it has really been a fantastic start. And like I said, it's an honor to be here and among such esteemed panelists and esteemed audience as well. So greetings to all my fellow brethren. And we've been in a bit of a darkness. We've possibly been all struck around as if we are in a storm. There's just dark clouds and lightning all around, and things have been pretty gloomy at each and every level. But I ask you today, can we turn COVID-19 from just being an adversity into an advantage? And is there a silver lining to all the clouds that we see around us? This, I think, is possibly one of the most famous pictures and is going to be around for a very long time, literally as a nightmare. And the fact that being COVID positive is not something that people are very happy about. We've seen that all over the country, and luckily these images are on a decline. And we are hoping that from just to be positive, which was not a very good thing a couple of months back, or maybe even today, what I would like to remind everyone is to stay positive, not positive for COVID-19, but to stay positive mentally, to stay healthy, and bring others back to a good health as soon as possible. So with that short introduction, let's look ahead and see what are the positives of this pandemic. I'll break it up into subheadings of healthcare, families and society, education and training, environment, even the economy and the political fallout as well. So for the healthcare part, I think all of us as healthcare professionals have realized the importance of moving back to the basics. We've realized that we can maximize use of technology. We can look at the actual cause benefit and a benefit harm evaluation. Again, it's a reminder not to blindly follow or just rely on something because it is maintained as published data. And most important, which our government keeps reminding us of, being Atmanirbhar, or being able to back self-reliance and self-sufficiency as the ideal way to move forward. What are the positives? It's been almost 1 year now since SARS-CoV-2 was identified, verified, and was subsequently declared as a pandemic. Today, randomized trials for treatment have been completed to some extent, even to the extent that artificial intelligence is able to distinguish COVID-19 parameters from other pulmonary infections in radiographic studies. Our industries have been able to ramp up their production, and in fact, even the lockdown, which took us all by surprise and something we had to actually just accept, have been able to transform and produce sufficient amount of medical supplies so that we were not really in a crisis as far as supplies was concerned. And all of us are following the development of the vaccines, which are going on at a very, very good rate, and there appears to be hope for the future. So, coming to the importance of back to basics, I think this is one of the biggest blessings. And if we can continue this, this is most important. Let's continue this of simple hand washing. We've seen much of anecdotal evidence, maybe because it's not really been published, but we've seen that overall hospital infections themselves have come down only because we have been reminded of the importance of washing hands, not just by healthcare professionals, but by all of us. We find that these reminders are there every day. And by and large, even though people are still not following it 100%, which we must ensure, by and large, we find that even people who are otherwise considered to be uneducated or poor or something else, they also are making some attempt to wear masks and maintain a little bit of physical distancing. We've been able to maximize use of technology because earlier it would be more of a discussion or maybe a random event. But today you can see that even online, there's been a lot of advantages of trying out telehealth. And to a large extent, I must say, we have been successful. I've even tried this portal myself, and it's very efficient, it's very well run, and it's quite easy for someone who just has a smartphone. You are able to get a consultant with not too much waiting time. Again, for all of us, whether we are students or whether we are faculty or even private practitioners, there is an important message that COVID has taught us of not to jump the gun, of not to just jump onto a new published technology or published ways of treating patients just because it has come out in a journal. We've seen in the past 6 to 8 months how much the even regulations by the WHO, even guidelines by the various agencies have literally been turned 180 or even 360 degrees at times. So this is important for us to understand, evaluate what exactly is a cause-effect relationship and not just blindly follow published data. Any studies which have been taken up, we have to evaluate and see that just because it is published, it need not be trustworthy. Initially, there was a big rollout of a lot of COVID studies, but with very, very small sample sizes. And again, the results were not being able to duplicate at other centers. Again, we can see the rapid rise in research papers that have been published, and it is still on the rise because everybody is trying to jump on to this bandwagon. But whether it is actually reliable is another matter. So let us remind ourselves to keep this READ, R-E-A-D, in mind of review, evaluate, assess the article, assess the data that has been published, and finally discuss it with our peers, discuss it with our friends. And once again, my compliments to the organizers for putting this together. And I'm sure over this whole conference that we'll be able to at least address this discuss part in full detail. There's importance to remember that we can be self-reliant and we can maintain our self-sufficiency. Our researchers, healthcare workers have all taken up the challenge that was thrown to us. We were totally unprepared. And yet I think we've done fairly well. But this we need to recognize, encourage each other, as well as support their efforts. This is a team from our very own ICER here in Pune. And this is almost a handheld ventilator that they had developed. So let's encourage them, let us support our own people, and this is the true way to move forward. Families and society, it's been a revelation for all of us, where we felt that we did not have time, we always felt that we were too busy, we were doing something good, whether in healthcare, whether in education, it didn't matter. But all of a sudden, when we were forced to be within the four walls of our house, yet we managed beautifully. We learned how to cook with each other, we learned how to play with each other, we actually spent time, and even online work, meetings, and even family events happened online, and life did carry on. What is most important, we understood the value of spending time with people that matter. Something I think all of us would have taken for granted, and today we understand the importance of that. Whether it was children playing with their grandmothers and not just on an iPhone or on the TV or playing an online game, but spending time with each other. The whole family came together and it brought a smile to our face, definitely. Again, whether it was young or old, you had Zoom meetings, you had birthday parties, and families kept in touch with each other using technology and being able to keep in touch despite all the lockdowns that did happen. Even in education and training, I still remember when we all started out and we were literally scratching our heads as to how to address the problem. The students were sent home all of a sudden, and some of them didn't have textbooks. But again, we had a lot of support from industry, and I must place it on record. Many of the publishers helped us out by giving us complete access to their website, giving us access to newer apps that they had brought out. And I still remember my first Zoom meeting that I took, and where a couple of the students started drawing on the screen, and everybody got flustered. But gradually, everyone learned the need to cooperate. We learned this new mindset, and I'm sure all the teachers and all the doctors here, you tell them to get together on Zoom, and it becomes as if they've been doing this for a very long time. So it's very good that we've been able to adopt, adapt, as well as encourage newer training paradigms. And even today, where we've got information or we are about to open our medical institutions, I'm sure that we will be able to change the lifetime thinking that we had of you just had to have classroom teaching or you just need to have practicals with all the students huddled around one patient. I'm sure we'll be able to look ahead and find out new ways and means of carrying on with our medical training. Again, these are names that we were not really bothered about, but today they have become a household name and a reality for all of us. This again has become a familiar sight for everyone, where the students come online and they're doing homework, they're doing their assessment, and even parents and teachers have adopted this new lifestyle fairly well, I must say. Again, these are possibly the most famous and popular words of this year, may I say, of am I audible? Please mute yourselves and can you see my screen? Because everyone has been getting together on Zoom. Again, a quick reminder that Zoom has been around for a very long time. It's not just been 2020. In fact, Zoom itself was launched in 2011, and Zoom as an app or as an online platform has been around since 2013. But the way that we have used it, and even in India, the way that we have adapted, whether it was Google Meets or Zoom or GoToWebinars, they've all been taken very easily. We've managed to master that technology. And even here today, we are so comfortably and so beautifully connected with each other. Again, our own industry has come up with apps, has come up with ways and means by which we can continue to be connected. So even in a post-COVID era, I'm sure we can keep these in mind because it has a lot of advantages of being connected in a virtual platform. We can remain to have a lot of meetings without having face-to-face, without wasting time in commuting from one place to the other. So we can continue these even when the lockdown and the other restrictions are finally lifted. Coming to, like I said, not moving from one place to the other causes reduction in traffic, reduction in emissions. And again, where we felt that, especially in India, it was not really something that would be possible because lack of awareness, lack of maybe stringent guidelines, lack of maybe even strict laws, everything was just going forward without any concern for the environment or the environmental damage. But here, when we were actually locked down, when people were unable to move, we could see the huge effect, positive, I must add, on the environment. Surprise, this may look like beautiful pictures from some foreign nation, but let me tell you, each and every one is from our own country. It's just that we, as polluting elements, were reduced and out of the picture. And if we can use this as a reminder that it is possible to keep our cities clean, to keep our surroundings clean, I think we are good to go for the next century even. Again, just let's look at this small video, not just to give you a little bit of a break, but it's something encouraging to see that in a city like Bombay, this was something beautiful that happened just a couple of months back. Not only that, even in other cities, we saw wildlife come out because once again, they were able to claim their territory as it were. And again, both nature and humanity were able to survive together. Even the famous Yamuna River, which people felt that despite all the government efforts, it would never get clean. Finally, we could see some clean water. And even the environment everywhere around, we had people posting such beautiful pictures on WhatsApp and on social media of how the reduced pollution changed the lives and changed the outlook of each and every one of us. For the economy, even though we feel that yes, it was damaged, and we know that a lot of people lost their jobs, a lot of people are still going through a very challenging time, but it will be on the upswing. And again, I urge each and every one of us to go ahead to look at the revival of small businesses, local traders, people who didn't let us down when everything else and there was no delivery on of Amazon, of online shopping. We found that our local businessmen, they came up, families got together, neighbors got together. So let's go back. And I think it's always good to get back to that minimalistic living and a lifestyle. And even this concept of work from home, we've seen that to a large extent, even in healthcare, like I said, telehealth went up to becoming a very practical solution. But we can keep it in mind, and possibly if we think differently, maybe we can have some changes in the future as well. There is good prediction that the economy is going to bounce back because, again, in India, we're blessed by having good numbers. And if we support each other, I'm sure the economy will get back from the very bad case that it was to something positive in the future. Again, for the publicity, for the media, everything put together, I think we can all support our Indian and Made in India can become famous as a brand. So, what needs to be improved? Let's keep the importance. And many of the speakers have been reminding us that we need to keep ourselves and our colleagues safe. Of course, to just say that everything is black and white and everything is going to be good, there are still a lot of unethical practices by few members of the society. And unfortunately, that gets highlighted in the media, that gets highlighted on social media. And this is where we must come together to reduce that. And then only can we be counted as true professionals. A little bit of discipline of our various societies, of the way that we function. And I'm sure this unity to face the challenges will be much better. If we can share the knowledge, the technology, go ahead in a system of solidarity, of supporting each other, being united, and most important, having a healthy respect for each other professionally. We have realized it during the lockdown, we've realized it throughout this year that we have all of us gone through, let's keep this at the forefront as we go ahead. So, what are the lessons for the future? I think these are very, very strong building blocks that we can build on. We need to have strong foundations. We need to look at the strength, the weakness, what were the opportunities that we missed, and what are the threats that are there in the future. This pandemic has taught all of us to prepare ourselves for any adverse effect in the long run. The complacency that had set in, all of us felt that life was good, everything was absolutely fit and fine, and suddenly we were thrown this whole tsunami, and then we had to learn to swim or sink. Again, a reminder of being self reliant, of being self sufficient, and not just relying on things that are imported, but we can do, and we can do definitely better if we decide to do so. We just need to think out of the box and give adequate recognition and support for innovation to our own brethren in all fields. So, as I conclude for today, let's keep these various principles that are basic to healthcare. Let them be all around us as a reminder while we keep the patient, while we keep our healthcare professionals at the center. Let these moral principles, let these ethical practices surround us so that this profession can go ahead. And like we said, we will be able to turn this adversity into a huge advantage. So I thank you for a patient hearing and best wishes as we discover a new way of life. It's going to be different. COVID is not going to go away in a hurry, but yet we will be able to live with COVID. We will be able to survive with COVID. And I'm sure we'll have a wonderful future. Thank you for a patient listening. In case there are any questions now, I will try and answer them. Thank you once again, organizers. Thank you once again to our distinguished audience for giving me this opportunity. Thank you.
Thank you, Dr. Derek D'Souza, sir, for his wonderful talk on this topic like turning adversity into advantages, and uh, telling what the COVID has given all positive things, including from simple hand washing to quality time with family, and regarding all technology aspects also. And for this wonderful mnemonics read, that is review, evaluate, assess, and discuss. We organizing team at MASTACON 2020 also tried to convert this adversity into advantage to make MASTACON 2020 successful with the help of technology and wonderful speakers. We will like to present e-momento to you, sir.
Thank you so much. I'm very touched. And again, a small request to each one of us. This is also something that we can really take forward in future. Let us keep in mind, because maybe tomorrow we'll be able to actually meet face to face and we won't be in a digital platform. But small things like these mementos and other things that we keep sharing with each other. Maybe we can think of, simple things of planting trees or sharing saplings.
Yes.
We as part of the UNESCO team, because we've been going around the country visiting a lot of universities in the past 4 to 5 years, and with all love and affection, we share these mementos. But very frankly, they also lead to environmental damage, not just in terms of cost, but even to dispose of it, and it really becomes a problem. So what we had started was that every time we have a visit, every time we have a conference, we plant a few trees in that area that we go to, as well as in case there were speakers who came from outside, we would give them some saplings to go back and plant either in their own institution or maybe in their houses or gardens. So I think a small change like this, because you can plant a fruit tree or you even give somebody a few fruit seeds, and that will go ahead. It's a wonderful gift to our children and grandchildren. And maybe this is one more learning that we can take away from this. So thank you. I really appreciate
Thank you,
this
sir.
opportunity, and I appreciate the e-memento above all. Thank you.
Thank you, sir. We have taken your suggestion, and the start of inauguration of this conference has been done by watering the plant. We have inaugurated the conference by not lighting that lamp, but we have watered the tree kept here.
I think let's use that as the benchmark for the future as well.
Yes.
Yes.
Thank you. Thank you.
Okay, thank you.
And with this, I announce the session concluded, and I request Dr. Kedar Kahate to felicitate the chairman. Dr. Kundan Chopade and Dr. Vankhedkar. And the next session will start at 2:10 after the lunch break. And I again announce that tomorrow morning, the sessions will start at 8:30 with inauguration of the MASTACON 2020 by tomorrow morning. The inauguration will be held at 8:30 in the morning by State IMA President Dr. Avinash Bhondwesa. And at 2:10, we have a lecture by Dr. Shailendra Vankhedkar, Savleshwar sir, on COVID vaccine. Will it contain the virus? Thank you.
Thank you all attendees for joining in. We will take a break, lunch break, and then we will be back at 2:10 and continue our lecture. So right now you can log off and you can join at 2 p.m. sharp. Thank you.